The operating room had gone silent in the worst possible way. Not the focused silence of a team working, but the dead quiet of people who had already given up. Blood soaked through the surgical drapes. The monitor was screaming a flat, continuous line. 4 doctors stood back from the table, gloves dark, eyes drifting toward the clock on the wall. Then a woman nobody in that room had bothered to learn the name of pushed through the door, walked straight to the table, pressed 2 fingers to a spot every single one of those doctors had overlooked, and said 4 words that stopped the room cold. And the patient's heart came back. If you're watching this for the first time, welcome. Hit subscribe right now, because this channel tells the stories that most people never hear about, the ones who were ignored, pushed out, and still changed everything. Drop a like if this is your kind of story, and leave a comment below telling me what city or country you're watching from. I want to see exactly how far this one travels. Now stay with me, because this is just the beginning. Harlow Creek, Montana was the kind of town that existed mostly as a reference point, somewhere between 2 larger places. Easy to pass through, easy to forget. The mountains held it in on 3 sides. The winters ran long and colorless, and the people who stayed had made a quiet agreement with the place. Don't expect too much, and it won't disappoint you. Kettner Valley Medical Center sat at the eastern edge of town, a 4-story building with pale brick walls and a parking lot that flooded every spring. It served 6 counties and operated, most days, just well enough to avoid catastrophe. It wasn't a bad hospital. It had working imaging equipment, a trauma bay that had handled everything from chainsaw injuries to multi-vehicle pileups, and a nursing staff that knew to function when things went sideways fast. What it's also had, running through every department like a fault line, nobody talked about, was a culture built around one person, shaped by 9 years of that person being the final word on everything that happened inside trauma. Dr. Preston Marlowe, chief of trauma surgery, was not the kind of man who raised his voice. He didn't need to. He had the slower, more durable kind of authority, the kind that made people second-guess their own observations before they opened their mouths. Technically excellent, respected by the administration, and absolutely precise about who he allowed to matter in his department. Nurses were there to execute. They were not there to think out loud, and they were especially not there to push back. That was the line, and it had been drawn so long ago that most of the staff had stopped being able to see it as a choice. It simply was the way things were at Kettner Valley, the same way the parking lot flooded every spring. Nobody questioned it. Nobody tried to fix it. That was the environment Nora Voss walked into on a Tuesday morning in late October. She arrived with a single duffel bag and a transfer file that listed her most recent posting as a mid-size hospital in Billings. She was 34 years old. Average height, no particular effort made with her appearance. The kind of face that didn't catch attention until you happened to hold eye contact with her for more than a second, at which point something registered that was harder to name. Not cold, not warm. Steady, in the way that things are steady after they've been tested past the point where most people would have cracked. The charge nurse who processed her intake was a woman named Diane Fuchs, heavyset, efficient, and visibly uninterested in small talk. She reviewed the Billings file, checked the transfer documentation, and produced a badge without looking up from the desk. Float pool, first 2 weeks, Diane said. You'll rotate between med-surg and the ER, depending on where the gaps are. Trauma runs its own staffing under Dr. Marlowe. You don't go in there unless he specifically authorizes it. Understood, Nora said. Diane looked up then, briefly, the way people do when something doesn't match the category they've already placed it in. Then she looked back at her paperwork. Orientation starts at 9. Don't be late. Nora was not late. She sat near the back of the orientation room, filled out every form in clean, precise handwriting, and said almost nothing for the entire 2 hours. Coordinator covering the session gave an answer to one of the procedural questions that was technically incorrect a detail about medication reconciliation timelines. And Nora let it go because correcting people in the first week created friction that lasted for months. She had learned that lesson more than once, in conditions considerably more consequential than a hospital orientation room. First shift on med-surg passed without incident. She moved through the floor at a pace that was neither rushed nor slow, remembered patient specifics without checking her notes twice, responded to call lights faster than the other float nurses, and communicated with the senior staff in short and accurate sentences. Performance, no effort to be liked. Just the work, done at a level that should have been unremarkable, but managed to be slightly better than what the floor was used to getting from float pool. Nobody mentioned it. That was fine. The first small disruption came on her fourth day, and it came out of nothing dramatic, just a patient in room 214, and a breathing pattern that wasn't quite right. The patient was a man named Garrett, 61 years old, 2 days post-abdominal surgery, and by every standard metric, doing acceptably. His oxygen saturation was at 94% when Nora checked it during her afternoon round, within the acceptable range, technically. But it had been 98 that morning, and his respiratory rate had climbed 6 points since the last documented check, and the particular quality of his breathing, the slight asymmetry in the effort of it, was something she had seen before in situations where waiting to be sure was how people died. Flagged it in the chart and brought it to the floor resident doctor. Isles, who was 3 months into his first year and managing the specific exhaustion of someone who hasn't yet figured out which worries to keep and which ones to set down. His SAT is 94, Dr. Isles said, scanning the chart with the practiced speed of someone reviewing faster than they're reading. Within range. It was 98 at morning rounds, Nora said. His respiratory rate has gone up 6 points in 4 hours. Post-surgical variation. It could be. I'd recommend a chest x-ray. Dr. Isles looked at her with the expression junior residents sometimes produce when a nurse pushes back a mixture of irritation and uncertainty that he hadn't yet learned to disguise. He ordered the x-ray, Nora suspected, mostly to end the conversation. It came back, showing early pleural effusion. Fluid outside the lung, caught early enough to manage without escalation, without an emergency, without any of the complications that would have arrived if it had been found 4 hours later. Dr. Isles documented it, ordered the correct intervention, and moved on without saying a word to Nora, which was more or less what she expected. What she didn't expect was being pulled aside by Diane Fuchs 40 minutes later. Dr. Isles mentioned, "You pushed him on the chest imaging." "For 214, Diane said. "I flagged a clinical change." He ordered the scan. It showed effusion. "I'm not saying the call was wrong." Diane's voice had the particular flatness of someone delivering a warning they've personally endorsed. "I'm saying that's not how things work here. You note concerns, you document them, and you let the physician make the call. You don't pressure them." The effusion would have been significantly harder to manage in another 4 hours. "That's not what I'm talking about." Nora held her gaze for a moment. "Okay," she said. "I hear you." She said it without argument, which satisfied Diane, who moved on. Both of them understood what had actually been communicated, and it had nothing to do with the X-ray. The message was clear and old and familiar. Know your place, stay in it, and don't mistake competence for permission to act like it matters. She had been receiving versions of that message for most of her adult life. She had gotten very good at absorbing it without letting it change her behavior, which was harder than it looked, and cost more than most people would ever realize. By the end of her first week, exactly one person at Kettner Valley had noticed her in a way that wasn't immediately negative. Soledad Bray worked nights in the ER, had been doing it for 11 years, and had the specific sharpness that comes from spending a decade watching things go wrong fast and learning to see them coming. She'd watched Nora complete a difficult IV placement on a patient with collapsed veins. Second, attempt clean, no backup called, and raised an eyebrow in a way that communicated something close to respect. You've done that before, Soledad said. A few times, Nora said. Where'd you train? Originally, I mean. Before Billings. Pause. Not quite long enough to be noticeable. Different places. Soledad studied her for a moment with the look of someone who recognizes a non-answer when they hear one and is deciding whether to press it. She let it go. You're better than the last 3 they sent from Float Pool. That's a low bar, Nora said. Soledad almost smiled. Yeah, it really is. Her first strict encounter with Dr. Preston Marlowe happened not in the trauma bay, but in the main corridor outside the surgical suites, where he was moving between cases at the pace of a man who treated being slowed down as a personal offense. He stopped when he clocked her badge. Float Pool. New. He ran a 2-second assessment, the kind that had nothing to do with clinical observation and everything to do with establishing where someone ranked. You're the Billings transfer, he said. Nora Voss. Marlowe. Trauma. He didn't offer a hand. Float Pool means you go where you're needed. My department is not a place for nurses who haven't trained in a trauma-specific environment. I don't have the bandwidth to manage people who don't already know the protocols. I wasn't planning to request a trauma assignment, Nora said. He looked at her for another second. He was searching for something deference, or excitement, or the slightly overeager quality that people often display when they meet someone important in a place where importance is carefully maintained. He didn't find any of it. What he found instead was a quality of stillness that seemed to mildly irritate him, possibly because he couldn't file it anywhere. Good, he said, and walked away. She watched him go without commenting, which was the correct decision. But she had read him clearly in those 30 seconds, the same way she had read men like him in environments where misreading someone's nature had direct physical consequences. He was a man whose authority had never been seriously tested, which had produced the specific fragility of people who confuse unchallenged control with genuine strength. Didn't hold his position because he could withstand pressure. He held it because he had built a department where pressure never reached him directly. Everyone around him had learned to absorb it on his behalf, and over 9 years they had become so practiced at it that most of them no longer noticed they were doing it. She went back to her floor and kept working. The break came 11 days in, and it came the way most real emergencies do, fast, loud, and demanding a response before anyone was fully ready to give one. Construction accident 3 miles east on Route 9. A man named Dale Pruitt, 43, brought in with crush injuries to both lower legs and vitals that the paramedics had been fighting for the entire 6-minute transport. The ER team took him at a run. Dr. Isles, first on. Backup called immediately, and within 5 minutes, Marlowe's second doctor. Rhea Sandoval was running the trauma bay with focused, methodical efficiency. Nora was 2 floors up, managing a post-surgical patient when the activation came over the overhead. She wasn't pulled. Float Pool didn't go to trauma activations without a specific request, and no one made that request. She kept working. 20 minutes later, her phone buzzed. Soledad, something's off with the construction patient. Sandoval's managing the legs, but his pressure keeps dropping, and nobody's landing on why. Nora read it. Finished the documentation she was mid-sentence through, because incomplete records created their own cascade of problems. Then she took the elevator down. The trauma bay was the functional kind of chaos directed, not panicked, everyone moving with a purpose. Pruitt was sedated on the table, the crush injuries being managed, imaging reviewed, surgical team being paged. Sandoval was sharp and focused, working the visible problem with real skill. Nora stood in the doorway for 7 seconds. That was enough. She had seen this specific pattern before, not in a trauma bay with full imaging and a team around her, but in a forward position with bad lighting and no equipment beyond what she was carrying. where the difference between recognizing something and missing it was the difference between a person living and not. What she was looking at was a man whose obvious injuries were being treated correctly and whose non-obvious injury was going to end him before the surgical team arrived if nobody changed direction in the next few minutes. She walked in. Dr. Sandoval level voice, not loud. His neck veins. Sandoval looked up from the wound site. Her expression shifted immediately to something harder. Your float pool. You're not assigned here. His neck veins are distended. His pressure's been dropping without a clear source. His breath sounds are unequal. The left side is diminished. No one in the room moved. Tension pneumothorax, Nora said. He needs needle decompression. Now, not in 5 minutes. The silence lasted 4 seconds. Sandoval's eyes moved to Pruitt's neck. Then to the monitor, which had just dropped another 9 points on the systolic. Then back to Nora, and the decision that passed across her face was visible: dismiss the unauthorized nurse and maintain the order of the room, or look at the patient. She looked at the patient. 14 gauge, she said, extending her hand without turning away from Pruitt. The decompression took 80 seconds. The pressure equalized. The monitor climbed back toward a number. That meant the patient was still in the conversation. Pruitt's color changed in the slow, specific way. That means something critical has just been caught at the edge instead of after it. Sandoval stepped back and breathed through her nose. She looked at Nora for a moment without speaking. He goes to surgery, Sandoval said to the room. Then quieter, directed only at Nora. You shouldn't be in here. I know, Nora said, and left. She went back upstairs. Finished the shift. Wrote her documentation in clean, clinical language, the observation, the communication, the intervention that followed, without adding a word of opinion or context. She logged out at 7:20 in the morning, drove back to the rented room she was keeping on Kettner Valley Road's east end, sat at the kitchen table, and stared at the far wall with a cup of coffee she forgot to drink. She had known something like this would happen. Except she had accepted the Harlow Creek posting precisely because it was small and quiet and far enough from everything that had come before it that nobody would have any particular reason to look closely. A float pool nurse with a billings transfer file. She had intended to keep her head down and do her work and exist without incident for as long as the posting lasted. She had not planned to be noticed this quickly. She should have been more careful. She knew that, but she had also stood in a doorway and watched a man die in the next 7 minutes if she didn't move, and there was a limit to how carefully she could calculate when that was the alternative. The response came faster than she'd expected, and from the direction she'd most anticipated. Marlowe heard about the trauma bay within an hour of her leaving the building. Someone had called him before his own shift started, which meant someone considered it urgent enough to interrupt his morning, which meant the story had been framed as a problem that required his attention rather than a float pool nurse who'd caught something his team missed. By 8:15, he was at the nursing station, speaking quietly with Diane Fuchs for 12 minutes. Whatever was said in those 12 minutes produced a visible result, Diane's expression, which operated in a narrow range between neutral and impatient on its best day, tightened into something more deliberate. Nora found out at the start of her next shift. Diane stopped her before she reached the floor. A concern has been raised, Diane said, using the specific phrasing that hospitals use when a decision has already been made and the conversation is a formality, regarding your presence in the trauma bay without authorization. I made a clinical observation that kept a patient alive, Nora said. You entered a restricted area without assignment, communicated the observation to the attending physician, and she acted on it. Dr. Marlowe has requested that you be moved to administrative support while a conduct review is open. No direct patient care until the review is resolved. Nora stood in the corridor outside the nursing station and kept her face neutral, which took a specific kind of effort that she had spent years developing. Administrative support. A desk. Insurance authorizations and discharge paperwork, while Marlowe decided at his own pace what the review would conclude. "How long does the review typically run?" she asked. Diane's expression didn't change. "That depends on the findings." Depended on Marlowe. That was the honest translation. The review would last exactly as long as he chose to let it last, and it would conclude with whatever outcome supported the version of events he had already settled on, because at Kettner Valley Medical Center, Preston Marlowe was the version of events. "I understand," Nora said. She spent the next 6 hours at a desk in the administrative wing, working through a backlog of insurance authorization requests with methodical efficiency and zero visible reaction. The work wasn't difficult. The degradation of it wasn't something she spent energy on, because she had been in situations where the external conditions were considerably more humiliating than a desk assignment. And she had learned that treating humiliation as a crisis was precisely how it became one. Processed the paperwork. She documented everything. She waited. At noon, her phone buzzed with a message from Soledad. "You need to look at the front entrance. Something's happening." Nora walked to the window at the far end of the administrative corridor. From there, angling slightly, she had a partial view of the hospital's main approach, the circular drive, the visitor drop-off, the road feeding in from the highway. 3 vehicles, not civilian, not ambulances, military-issue SUVs, dark, moving with the unhurried precision of a convoy that knows exactly where it is going and has no uncertainty about what happens when it gets there. They pulled into the main entrance lane and stopped. The doors opened. 4 figures stepped out. The one in front was a tall man in uniform, moving with the particular bearing of someone whose authority was not institutional but personal, earned in conditions that had nothing to do with hospital corridors, corrections, or administrative reviews. Nora stood at the window and felt something shift in her chest. Not panic. Something older and quieter than panic, the sensation of a thing you have spent a significant amount of time hoping would not arrive, arriving anyway. She watched the figures cross toward the main entrance. Watched the lead man stop at the security desk and speak to the officer there. Watched the officer look down at whatever had just been placed in front of him, look up, and reach for the phone. Whatever name he was about to dial, it was not Preston Marlowe's. Nora watched the security officer hold the phone to his ear for exactly, he put it down and picked it back up again, the way people do when the first call doesn't connect and they're not comfortable with the delay. The lead figure in uniform stood at the desk with the particular patience of someone who has waited in worse places for longer periods and considers this a minor inconvenience at most. The other 3 spread out behind him in a loose formation that wasn't aggressive but wasn't casual, either the automatic positioning of people trained to always know where the exits were. She stepped back from the window before any of them looked up. Her hands were steady. That was the first thing she checked, because she had learned a long time ago that her hands told the truth even when her face didn't. They were steady. Good. She needed them to stay that way while she figured out what the next 10 minutes were going to require of her. Because one thing was already clear. Whoever had walked through that entrance had not driven 3 vehicles to Harlow Creek, Montana on a Tuesday afternoon to look at the view. She went back to the desk, sat down, opened the authorization file she'd been working through, and stared at it without reading it. The administrative wing was quiet at this hour. Two other staff members at the far end of the room, both focused on their own screens, neither paying attention to her. Corridor outside was empty. From where she sat, she couldn't see the main entrance anymore, which meant she was working with whatever information she'd gathered in those 90 seconds at the window, and that information was limited but not ambiguous. Military transport. Senior officer, based on the bearing and the way the other 3 deferred to his positioning, without being told to. Not a medical transport. There was no patient, no urgency to the movement, no equipment being offloaded. They had come for a reason that involved a conversation, not a procedure. She had 3 possible explanations, and she ran through them in order of likelihood the way she had been trained to assess a situation with incomplete information. 1. A military patient was being transferred to Kettner Valley, and someone from the service branch was here to coordinate the logistics. Possible, but the convoy size and officer rank didn't fit the profile of a routine transfer coordination visit. 2. There was a security issue, something adjacent to the hospital, something that required military presence as a precaution. Also possible, but again, 3 vehicles and a senior officer for a precautionary visit was disproportionate. 3. They were here for a specific person, not the hospital, not a patient, a person. She sat with option 3 and felt the quieter register of that shift in her chest again. 6 minutes passed. She processed 2 authorization requests without retaining any details of what she'd approved. Then her phone buzzed again, and this time it wasn't Soledad. It was an extension she didn't recognize, internal, from somewhere in the building. Stared at it for 1 ring, 2 rings, and then answered because not answering was its own kind of decision. "This is Voss," she said. A pause. Then a voice she didn't recognize, measured, carrying the specific acoustic quality of someone who had spent years speaking in environments where being heard clearly was not guaranteed. "Is this Nora Voss? Currently assigned to administrative support, Kettner Valley Medical Center?" "Yes," she said. "This is Colonel David Ferran, United States Army Medical Command. I'm at your facility's main entrance. I need to speak with you directly. Can you come down?" She was quiet for 2 seconds. "Can I ask what this is regarding, Colonel? I'd prefer to have that conversation in person." Another pause, shorter. "It's not a legal matter, if that's your concern. We're not here to create a problem for you. We're here because we need your help." She looked at the authorization file on her desk, looked at the window at the far end of the room, through which she couldn't see the entrance from this angle but knew exactly what was parked in front of it. Looked at her hands, which were still steady. "I'll be down in 5 minutes," she said. Closed the file, logged out of the workstation with the same automatic precision she'd applied to every task since she arrived at Kettner Valley, and walked to the elevator. The administrative wing occupied the 3rd floor's east side. The main entrance was ground level, center. She had 30 seconds in the elevator to decide what version of herself she was going to walk out as, and she used every one of those seconds to make a calculation she had been hoping she wouldn't need to make for at least another year. The lobby of Kettner Valley Medical Center was a standard institutional space, pale floors, a reception desk anchoring the center, seating areas that were never quite comfortable enough to encourage lingering. When Nora came through the elevator doors and turned toward the entrance, the 4 figures were waiting near the security desk in a configuration that managed to occupy the space, without drawing significant attention from the 2 visitors and 1 orderly who were the only other people in the lobby at that moment. The securities officer behind the desk was doing a credible impression of someone very focused on his monitor. Colonel Ferran was taller than he'd appeared from the 3rd floor window, mid-50s, close-cropped silver hair, the lean build of someone who had never stopped treating physical conditioning as a professional obligation. He had eyes that processed a room quickly and settled without fidgeting, and when he looked at Nora walking across the lobby toward him, something in his expression shifted almost imperceptibly. The way people look when they've been shown a photograph of someone and then see them in person and are recalibrating the 2 versions against each other. "Nora Voss," he said. "Not a question." "Colonel Ferran," she said. He extended his hand, and she shook it, which was when she registered that the other 3 weren't aides or administrative personnel. They were medical. She could see it in the way 2 of them were watching her. The specific professional attention of people who are evaluating another medical professional rather than managing security. One of them was a woman in her 40s with a physician's pin on her collar. The other 2 were younger, but carried themselves with the focused economy of people who had worked in field conditions. "Is there somewhere private we can speak?" Farron said. "There are consultation rooms off the main corridor," Nora said. "This way." She led them through the lobby, through the corridor that branched left past radiology and toward the consultation suite. She was aware of the security officer watching them go. She was aware that someone at the nursing station near the corridor junction glanced up and then looked a second time. She kept her pace even and her expression neutral and pushed open the door to consultation room 2, which was empty and would be for the next 40 minutes, according to the scheduling board outside it. Lixed Sem Phi. Farran came in, the physician and one of the younger officers followed. Third stayed outside, which told Nora something about what kind of conversation this was going to be controlled, not open-ended. They had prepared for it. This wasn't improvised. She closed the door and turned to face them. "How long have you been at this facility?" Farran asked. 11 days, she said, under a Billings transfer. "Yes," he nodded, without judgment or particular emphasis. "We know about the incident in the trauma bay last night. Tension pneumothorax." He let that sit for a moment. "That's not why we're here, but it's consistent with why we're here." The physician spoke for the first time. Her name tag read Calloway. "We have a patient, Nurse Voss. He was transported to 6 hours ago under a SITS or a civilian identification for what were documented as routine cardiac symptoms. He is not a routine cardiac patient, and his condition is not routine." Nora looked at her steadily. "Who is he?" Farran answered. "Brigadier General Wallace Steele. He sustained a blast injury 18 months ago during an overseas assignment. The injury was managed in the field and subsequently at a military medical facility, where he was cleared for return to duty. 3 weeks ago, he began presenting symptoms that don't align with the original injury profile." "What's the current presentation?" Nora asked. "Intermittent cognitive disruption, pressure-type headaches, localized behind the right orbital, and 2 episodes of transient right-side motor weakness in the past 10 days, Calloway said. "The admitting team here has him on a cardiac monitoring protocol based on the documented referral." Nora was quiet for a moment. "That's not cardiac." "No," Calloway said. "We don't believe it is." "What does the admitting team think?" "They haven't gone beyond the documented referral diagnosis. The general was admitted under civilian credentials, and the admitting physician has no context for the injury history." Calloway's expression was controlled, but not entirely. There was tension beneath it, the kind that lives in people who know something is wrong and have been watching the clock. "We need someone who can look at this without the framing of the referral diagnosis. Someone who understands blast injury presentation and the specific ways delayed complications can read as something else entirely." The room was quiet. Nora looked at Farran. "You came to Harlow Creek for this." "We came to Harlow Creek for you," he said. "Specifically." There was no version of that sentence she could pretend to misunderstand, and she didn't try. "My file says Billings transfer," she said. "Your file says a lot of things," Farran said. "What your file doesn't include is anything from the 6 years before Billings, which is an absence that takes a specific kind of effort to arrange." He wasn't accusatory. He was precise. "We're not here to disrupt whatever you've built here. We're here because the general situation is deteriorating, and the people responsible for his care have him working from the wrong diagnosis. And there are very few people with the combination of knowledge and experience needed to look at this particular presentation and understand what they're actually seeing. And you think I'm one of those people," she said. "We know you are," he said. She looked at the wall to her left, which was blank and institutional, and gave her nothing to focus on except the weight of what she was being asked and what saying yes to it would cost her. She had structured her entire existence at Kettner Valley around not being this person. She had taken the float pool assignment and the small room on Kettner Valley Road and the transfer file with the careful gap in it so that she could keep doing the work she was trained to do without being the person everyone turned to when nothing else had worked, because that person had a cost attached to her that Nora had already paid twice and was not certain she could afford to pay again. If I see him, she said slowly, I'm doing it as a nurse. I'm not practicing outside my scope. I look, I communicate what I observe, and a physician makes every clinical decision. Agreed, Calloway said immediately, which told Nora that they had already discussed this boundary and had decided in advance to accept it. And this conversation stays in this room, Nora said, looking at Farron. As long as it can, he said, which was honest in a way she appreciated more than a cleaner answer would have been. She thought about Dale Pruitt in the trauma bay the night before, and the way Sandoval's eyes had moved to the patient's neck veins after a 4-second silence. She thought about Garrett in room 214, whose effusion had been caught early enough to manage, without escalation. She thought about the 6 hours she had spent at an administrative desk processing insurance authorizations, because Preston Marlowe had decided that a nurse who saw something his team missed was a problem to be managed rather than a resource to be used. She thought about a man admitted to this hospital under the wrong diagnosis, with a blast injury complication that was going to keep getting worse, while the admitting team treated his cardiovascular system for something he didn't have. Which room? She said. Farron told her. She reached for the door handle. Then she stopped, hand on the door, and turned back to face him. Colonel, when this is over, whatever happens with the general, whatever the outcome is, I need you to understand that I came here to do a specific job in a specific way. What you know about me, what your files say about who I was before Billings, that doesn't change what I'm doing here now. Farron looked at her for a long moment. His expression had the quality of someone who has heard a version of this before and understands both what is being said and what cannot be said alongside it. Understood, he said quietly. She pushed open the door and walked out into the corridor, and somewhere 2 floors above her, behind a desk in the administrative wing, an insurance authorization file sat open and unfinished. And Dr. Preston Marlowe had absolutely no idea what had just walked back into his hospital. Corridor's outside consultation room, too, was empty when Nora stepped into it, which meant she had approximately 90 seconds before someone on the nursing staff connected the military vehicles in the front lot to the 4 people who had just disappeared into a consultation room with a float pool nurse on administrative leave. 90 seconds was enough. She had moved through worse situations on worse timelines. Room 318 was in the medical surgical wing on the 3rd floor, east side, the same floor, where she had been processing insurance authorizations 40 minutes ago, which meant she knew exactly which nursing station covered it and which staff members were on at this hour. She took the stairs instead of the elevator, came out at the east stairwell door, and walked the corridor at a pace that was purposeful, without being fast enough to register as urgent. The nursing station for 310 through 330 was staffed by 2 nurses. She recognized from her float pool rotations a younger woman named Petra, who was generally focused on her documentation, and an older man named Russell, who noticed everything and said very little. She nodded to both of them without slowing down. Russell glanced up, tracked her for a moment, and went back to his chart. Room 318 had a closed door and a patient identifier on the board outside that read Delaware. Frank's civilian name, civilian admission. Nothing on the board that flagged anything beyond a cardiac monitoring protocol. She knocked twice and pushed the door open without waiting, because hesitating at a patient's door was a signal. And she was not in a position to send signals right now. The man in the bed was 61 years old and looked like someone had taken a person who had spent decades being physically formidable and put them through a process that had reduced the exterior without touching whatever was underneath. He was broad through the thinner than his frame was built for, with the kind of face that had been weathered by conditions that had nothing to do with age. An IV line ran into his left forearm. The cardiac monitor beside the bed showed a rhythm that was regular and unremarkable. He was awake, and when Nora came through the door, he looked at her with eyes that were sharp in a way that his current presentation had no business supporting. "You're not the attending," he said. His voice was hoarser than she expected, slightly effortful, but the assessment behind it was clean. "No," she said, moving to the side of the bed. "I'm Nora Voss. I'm a nurse here. Colonel Farron asked me to look in on you." Something shifted in his expression, not relief exactly, but the adjustment of someone who has been waiting for a specific thing to happen and is now recalibrating slightly the fact that is happening slightly differently than anticipated. "Farron found you faster than I expected," he said. "I was already here," she said, and left it at that. She pulled the bedside chart from its holder and scanned it, quickly admitting diagnosis. Cardiac monitoring protocol. The medication list, the vitals from the past 6 hours. Then she set it down and looked at him directly. "General Steele, I need to ask you some questions, and I need honest answers, not managed ones. Can you do that?" He almost smiled. "Depends on the questions. When did the headaches start?" 3 weeks ago. "Maybe 3.5. Location? Behind the right eye. Sometimes across the forehead on the right side. Constant or intermittent? Intermittent, worse in the mornings." He paused. "And when I turn my head fast? There's a lag, like the picture takes a second to catch up." She noted that. The motor weakness episodes describe what they felt like. He was quiet for a moment, and she recognized the particular quality of that pause, not evasion, but the effort of someone translating a physical experience into words with precision. "The first time, I thought I'd slept on my arm wrong. Right hand couldn't grip for about 4 minutes. The second time was my leg. Walking to the bathroom, my right knee buckled. Lasted maybe 6 minutes. Any nausea with the headaches? Sometimes. Low grade. Vision changes?" He hesitated, which told her the answer was yes, and that he had been minimizing it. "Some blurring. Right eye. It comes and goes." She looked at the cardiac monitor, then back at him. "What was the original injury? Specifically, IED. 18 months ago. Right side of the vehicle. I took the edge of the blast shrapnel. Mostly. Some of it went here." He touched the right side of his head, behind his ear, low on the skull. The motion was careful, habitual, the gesture of someone who has touched that spot many times since the injury. "They cleared me at the field hospital. Imaging was clean at the time. Follow-up at Langton showed no structural damage." Nora stood very still. She was running a calculation that she already knew the answer to, had known it from the moment Calloway had listed the symptoms in the consultation room, but she needed the specific location of the original injury to complete it. Behind the right ear, low on the skull, right-sided headaches, right-sided motor weakness, right-sided vision changes. The imaging had been clean 18 months ago, which was consistent with an injury that had produced slow intracranial changes that wouldn't have been visible on initial imaging and would have taken months to develop into a presentation like this one. "Has anyone here ordered a CT or an MRI since you were admitted?" she asked. "Cardiac imaging," he said. "Echo. No head imaging." Breath through her nose. "I need you to understand something, General. Speckle. Professionally, I'm a nurse. I cannot order imaging, and I'm not going to tell you what I think this is while you're in a room where the only diagnostic work being done is on your heart. What I can tell you is that I'm going to communicate what I've found to the attending physician on your case, and I'm going to recommend additional imaging." "The attending thinks I have an arrhythmia," Steele said. "I know. He's been very confident about it." "I know that too," Nora said, and the steadiness in her voice came from a place that had nothing to do with confidence and everything to do with the specific practice of staying functional when you're looking at something that makes you want to move fast and loud. "Give me 20 minutes. She left the room and walked back toward the nursing station, where Russell was still working through his charts, and Petra had been joined by a third nurse coming on for a shift handover. The attending physician on Steele's case was listed on the board as Doctor. Graham Felt, she recognized the name, had seen it on documentation during her float pool rotation. Felt was a hospitalist, mid-career, competent within a defined range, and deeply invested in the validity of the diagnosis he had already entered into the system. She called the hospitalist line and asked for him. Called back in 4 minutes. "This is Felt, doctor." "Felt, this is Nurse Voss. I'm on the floor covering 318. I've just completed a bedside assessment on your cardiac monitoring patient, and I have some observations I'd like to share." A pause. "I wasn't aware float pool nurses were covering 318. I was asked to look in on the patient by family contacts. Not entirely false. He's presenting with a symptom cluster that I think warrants additional imaging, specifically cranial. He's reporting right-sided headaches, 2 episodes of transient right-sided motor weakness in the past 10 days, and intermittent visual disturbance in the right eye. He has a history of a right-sided blast injury to the lower posterior skull 18 months ago." The silence on the other end was the particular kind that meant Felt was deciding how to respond to being told he had missed something, which was a different kind of silence than the one that meant someone was genuinely considering new information. Patient's presenting complaint was cardiac, Felt said. The referral diagnosis was a probable arrhythmia. His cardiac rhythm has been regular since admission, Nora said. His symptom history is not consistent with an arrhythmia presentation. I appreciate the input. His voice had taken on the specific flatness of a physician who has decided to be polite while dismissing what he's hearing. I'll review the chart when I make afternoon rounds. Afternoon rounds are in 4 hours, she said. That's correct. Kept her voice even. I'd recommend the review happen sooner, doctor. Felt. Another silence, this one shorter and sharper. Nurse Voss, I'll note your concern in the chart. Is there anything else? She had 2 choices. She could push harder on Felt and produce a version of the conversation she'd had with Doctor. Aisles about Garrett's X-ray, except with higher stakes, and a physician who was less uncertain and therefore less movable. Could change her angle. No, she said. Thank you, doctor. Felt. She hung up and stood at the nursing station for a moment, looking at nothing in particular, while she worked through the geometry of the situation. Felt wasn't going to move in the next 4 hours. He had a diagnosis, a referral to back it up, and the institutional inertia of a chart that had already been built around cardiac monitoring. Convincing him required either evidence he couldn't dismiss or authority he couldn't override, and she had access to neither through the normal channels, especially not while she was technically assigned to a desk in the administrative wing and had no business being on this floor at all. She went back to the stairwell, not down to the administrative wing, up to the 4th floor, where the office suite for the medical department heads was located, and where, according to the staff directory she had memorized during her first week, out of simple professional habit, the chief of medical staff, Dr. Annette Darrow, kept hours on Tuesday and Thursday afternoons. She had not met Darrow. She had no standing to walk into her office. She was a float pool nurse on administrative leave, which meant she had approximately as much institutional standing right now as someone who had wandered in from the parking lot. She knocked on the outer office door anyway. The assistant who answered was a young man named, according to his lanyard, Marcus, who looked at Nora's badge and her expression and performed the calculation that administrative assistants perform when someone arrives without an appointment and doesn't look like they're going to be easily redirected. I need 5 minutes with Dr. Darrow, Nora said. I have a patient safety concern regarding a current admission. Dr. Darrow is in a meeting until 3. It's 12:47, Nora said. Is the meeting in this building? Marcus blinked. Yes, but can you get a message to her? Just the patient safety concern. She decides it can wait until 3. I'll come back at 3. He looked at her for a moment, then picked up his phone. He spoke quietly, turned slightly away from her and listened. Then he turned back. She'll be out in 10 minutes. Nora sat in the chair outside the office and waited, and while she waited, she thought about the timeline she was working against. Steele's symptoms had been escalating for 3 weeks. The motor weakness episodes were getting closer together. The first and second had been 10 days apart, and if the pattern was what she thought it was, the third would come sooner. The visual disturbance was intermittent now. Intermittent was a word that meant it hadn't become constant yet, which meant there was still a window. But the windows in neurology had a way of closing faster than people expected when the underlying cause was pressure. Dr. Annette Duro came out of the conference room at 12:59, which meant she had cut the meeting short rather than let it run to 10 minutes, which told Nora something useful about her. She was in her early 60s, compact and deliberate in her movements, with reading glasses pushed up on her head, and the expression of someone who is perpetually sorting incoming information into categories of urgency. "Nurse Voss," she said, "my assistant says you have a patient safety concern." "Room 318, Nora said, standing. "Admitted this morning under a cardiac monitoring protocol. The presenting symptom history is not consistent with a cardiac etiology. He has a posterior skull blast injury in his history, and he's presenting with right-sided headaches, transient right-sided motor weakness occurring twice in the past 10 days, and intermittent right eye visual disturbance. He needs cranial imaging, and the attending has him scheduled for a chart review at afternoon rounds." Durrell looked at her without speaking for 2 full seconds, which in a hospital administrator was the equivalent of a much longer pause. "You're the float pool nurse on administrative leave." "Yes." "What's your basis for the assessment?" "I sat with the patient and took a direct symptom history. His reported symptoms have not been fully documented in the current chart because the admitting interview was framed around the referral diagnosis." "Who asked you to see this patient?" Nora held her gaze. "His family contacts. They had concerns about the current diagnostic approach." Duro was quiet again. She was running her own calculation, and Nora watched it happen without trying to influence it, because pushing Duro would produce the opposite of what she needed. The woman was not felt she didn't have a diagnosis to protect, and she had responded to patient safety concern by cutting a meeting short, which meant she took it seriously as a category. "I'll speak to Dr. Felt," Duro said finally. "The imaging should happen today," Nora said. "I understand the implication of what you're describing, Nurse Voss." A pause. "Go back to your assignment. It wasn't warm. It wasn't a guarantee. But it was a different response than the one she'd gotten from Felt, and Nora recognized the difference clearly enough to accept it and move. She went back down to the administrative wing, sat at her desk, and opened the authorization file she'd been neglecting all morning. Processed 3 requests in the next 40 minutes. Her phone didn't ring. Nobody came to the desk. The administrative wing was as quiet as it had been when she left it, and the quiet was the wrong kind, not settled, but suspended, like the air before a pressure change that everyone in the building was going to feel whether they were looking for it or not. 2:15, Soledad sent her a message. "Felt is in 318, and Doro is with him." Nora read it and set the phone face down and kept working. At 3:40, a different message. They moved the patient. Radiology. She let out a breath through her nose. That was the imaging. That was Duro moving Felt, which was what she had calculated would happen, and what she had not let herself fully count on until it had actually happened. Because counting on things before they occurred was how you made decisions based on wishful thinking, instead of what was actually in front of you. She had done what she could do from the position she was in. The rest of it was in the imaging, and the imaging would either confirm what she suspected or it wouldn't. And either way, she had done her job, which was the only metric she had ever been able to reliably use. She was mid-sentence on an authorization request when the door to the administrative wing opened, and Preston Marlowe walked in. He was not alone. Diane Fuchs was with him, half a step behind and slightly to his left, which was the specific positioning of someone who has been brought along to witness rather than to participate. Marlowe crossed the room toward her desk with the particular energy of a man who has received information he considers both inaccurate and an affront, and who has decided that the most effective response is to address it before it develops further. Nora saved the document she was working on, closed the window, looked up. "Dr. Marlowe," she said. "I've just had a conversation with Dr. Duro," he said. He kept his voice controlled, which with Marlowe meant the anger was running underneath rather than at the surface, which was actually harder to manage than if he'd simply been loud. "She tells me a float pool nurse, on administrative leave, consulted directly with a patient in 318 without physician authorization, and then escalated an alternative diagnostic theory to the chief of medical staff. I communicated a patient safety concern," Nora said. "You are not currently authorized for patient contact," he said. "You are on administrative assignment, pending a conduct review. What you did this afternoon is a direct violation of the parameters I laid out with the charge nurse. The patient in 318 is being treated for a cardiac condition he doesn't have," she said. "His symptom history points to intracranial pressure secondary to a blast injury. He needed imaging. That is not your determination to make." "I didn't make a determination. I communicated an observation to the physicians responsible for his care." Marlowe leaned forward slightly, both hands flat on the desk surface in front of her. It was a deliberate physical choice, not threatening exactly, but designed to compress the space between authority and consequence until they felt like the same thing. "Let me be precise about something, Nurse Voss. You came to this hospital 11 days ago with a transfer file and a billings posting. You have been here less than 2 weeks. In that time, you have entered my trauma department without authorization, contradicted a resident's clinical judgment, and now bypassed the attending physician on an active case to go directly to hospital administration. That pattern tells me something about how you operate, and it tells me this facility is not the right fit for you." He said it with the careful pacing of someone delivering a verdict rather than an opinion. Not a threat, a conclusion. "I understand your position," Nora said. "I don't think you do. I'm recommending to administration that your float pool contract be terminated." He straightened. "Effective end of this week." The room was very quiet. Diane was looking at the wall to the left of Nora's desk. Even she, Nora noted, was not looking at Marlowe directly. Nora held his gaze for a moment. She thought about steel in radiology right now, the imaging machine working through whatever it was going to find, the answer being assembled in digital slices while this conversation happened in a room 2 floors away. She thought about Dale Pruitt recovering from surgery with both lungs working correctly. She thought about Garrett in room 214, whose pleural effusion had been caught early enough that he'd gone home 4 days ago without ever knowing how close he'd come to a significantly worse outcome. She thought about what Marlowe was and what he wasn't. "Okay," she said. He seemed to expect more a protest or a defense, or at minimum the visible effort of someone trying to hold their position. The absence of it seemed to mildly throw him, the way her stillness had thrown him in the corridor the week before. He held the desk for another second, then straightened fully. "Diane will send the formal notification," he said, and left. Diane stood in the room for a moment after he was gone. She was looking at Nora with an expression that was harder to read than her usual operational neutrality, not quite guilt, not quite apology, but something in the vicinity of both that she clearly had no intention of putting into words. "I'll send the paperwork by end of day," she said. "Thank you," Nora said. Diane left. Nora turned back to her workstation and finished the authorization request she'd been writing before the interruption. Because it was unfinished and it needed to be finished, And because the specific discipline of completing the task in front of you, regardless of what had just happened, was one of the first things she had ever been taught, and one of the last things she intended to give up. Her phone buzzed at 4:22. Soledad again. Radiology is sending Felt something. I don't know what, but he's been in there for 20 minutes. Then, 8 minutes later, Nora. Whatever you told them to look for. They found it. She read that message twice, set the phone down, picked it up again, and read it a third time. Not because the words were unclear, but because she had learned the hard way not to respond to any news, good or bad, before she had read it enough times to be certain she was reading it accurately and not the version she wanted it to say. Whatever you told them to look for, they found it. She had been right. She had known she was right when she was standing at Steele's bedsides, running through his symptom history. And she had known it in the way that comes not from guessing, but from pattern recognition, built on years of seeing the same presentation in conditions that required getting it right the first time, on time. Because there was no second time. And being right meant Steele was going to get the correct treatment. It meant the cardiac monitoring would be stopped, and the actual problem would be addressed. And a man with a blast injury complication that had been getting quietly worse for 3 weeks was going to get what he needed before it progressed to the point where what he needed became significantly harder to deliver. Being right also meant something else. It meant Marlowe had just terminated her contract for correctly identifying a critical diagnosis that his facility had missed. She saved the final authorization request, logged out of the workstation for correction for the last time, and was reaching for her badge lanyard when the door to the administrative wing opened again. It was not Diane. It was not Marlowe. It was Colonel Farron, and behind him was Dr. Calloway, and the expression on Farron's face was the specific expression of someone who has just received information that has shifted the terms of a situation they thought they understood. They found a subdural hematoma, he said, without preamble. Slow developing, right temporal lobe. The attending is escalating to neurosurgery right now. I know, Nora said. I just heard. The neurosurgical team they're calling in is from Billings. They'll be here in 3 hours. He paused. The lead neurosurgeon hasn't seen a blast injury-associated hematoma of this type. Calloway has, but she's not a surgeon. The procedural approach for this specific presentation is different from a standard hematoma, Nora said. Yes. She looked at him. You're asking me something. The general surgical outcome is going to depend significantly on the operating team understanding the specific considerations for this type of injury, Farron said. There is relevant procedural knowledge that isn't in the standard neurosurgical literature. You have that knowledge. I'm a nurse, she said. Can't operate. We're not asking you to operate. We're asking you to be in the room. She stood behind the desk in an administrative wing where she had spent 6 hours processing insurance requests after being removed by a man who was about to discover that he had terminated her contract approximately 4 hours too. Specs early, and she looked at the colonel and thought about all the reasons to say no and how none of them, when she laid them out honestly, had anything to do with the patient. Dr. Marlowe is going to be informed of this, she said. Dr. Marlowe is already being informed that his hospital has a military patient with a neurosurgical emergency. Farron said, We are making a formal request for your involvement through channels that are above his authority to deny. The air in the room changed, not because of anything visible, not because of any sound. But Nora felt it, the way you feel the temperature shift before a front moves through the specific sensation of something that has been one way for a long time becoming irrevocably something else. Give me 10 minutes, she said. She was already moving toward the door when her phone buzzed one more time. She looked at it without slowing down. The message was from Soledad, and it was only 4 words. Marlowe just got called. She put the phone in her pocket and kept walking. Because The next 10 minutes were going to require everything she had, and there was no version of what came next that she was going to navigate by standing still. The 10 minutes she had asked for turned into 7, because 7 was what the situation actually allowed. Nora went to the staff locker room on the second floor, changed out of the civilian clothes she'd worn to the administrative wing, and into a set of scrubs from her locker, and washed her hands at the sink while looking at her own reflection, with the specific neutrality of someone taking inventory rather than looking for reassurance. She had done this before, not in a hospital, not with a neurosurgical team from Billings and a colonel standing outside a consultation room, but the essential shape of it was the same. Walk into a situation that is already in motion. Understand it faster than the people already inside it. Do the specific thing that needs doing and nothing beyond that. Get the patient through. She had not always gotten every patient through. That was the part nobody talked about when they talked about people with her kind of background, the ones who didn't make it. The decisions made correctly that still produced the wrong outcome because the injury was too far gone, or the conditions were too far outside what any intervention could overcome. Carried those the way you carry weight that doesn't go away, but that you learn to distribute so it doesn't stop you from moving. She was not going to think about them right now. She dried her hands, closed her locker, and walked out. Farron was waiting at the end of the corridor, with Calloway beside him. A fourth figure had joined them, a man Nora hadn't seen before, younger than Farron by a decade, in civilian clothes, but carrying himself with the same trained economy of movement. He was introduced as Captain Reeves, medical liaison, and he had a tablet in his hand that he extended to Nora as she approached. Imaging, he said. She took it and looked at the CT scan on the screen. The hematoma was visible immediately, a lens-shaped hyperdense collection in the right temporal region. The classic presentation of an acute on chronic subdural, which meant the initial injury had produced a slow bleed that had been accumulating for weeks before crossing into the acute phase. The midline shift was subtle but measurable, 3 millimeters, maybe 3.5. Not catastrophic yet, not the kind of number that meant the window had already closed. Kind of number that meant the window was closing, and the specific location, right temporal. Posterior margin, the area above the petrous ridge, was what made this complicated in ways that a standard neurosurgical approach wasn't going to fully account for. "Who's the lead surgeon coming from Billings?" she asked. "Dr. Marcus Trent," Calloway said, "neurosurgery attending, 8 years post-residency. Strong general profile, blast injury experience. 2 cases, both straightforward presentations, frontal lobe, no posterior involvement." Nora handed the tablet back to Reeves. "The posterior margin of this hematoma is sitting directly over the venous drainage anatomy that blast injuries frequently disrupt. Trent goes in with a standard temporal approach and doesn't account for the possibility of compromised venous architecture in that region. He risks converting a manageable bleed into an uncontrollable one, which is exactly why you need to be in that room," Farron said. "Does Trent know I'm being requested?" "He knows a clinical consultant with relevant experience is being made available," Farron said. "He doesn't know the specifics of your background. He's going to ask. Let him ask." She looked at Farron for a moment. There was a version of this conversation where she pushed harder on the disclosure question, where she laid out exactly what it would mean for Trent to find out mid-surgery that the consultant standing beside him had a background she'd spent 3 years carefully burying, and what that kind of disruption could do to a surgical team's cohesion at a critical moment. She filed that version away. It was a real concern, and she would need to manage it, but managing started with getting into the room, and getting into the room required moving in the next 4 minutes. "Where's Marlowe right now?" she asked. "3rd floor, Reeves said, checking his tablet. He was called to a meeting with Dr. Duro and a hospital administrator. Colonel Farron has already submitted the formal request for your surgical consultation through the Army Medical Command Liaison Office. The request has been acknowledged by Kettner Valley Administration, which means Marlowe can't block it directly, Nora said. Correct. He can object. He can document his objection. He cannot override a formal military medical consultation request for a patient under Army jurisdiction. She absorbed that. He's going to make this difficult afterward. That's afterward, Farron said. It was a simple statement, and it was completely accurate, and she recognized it as such and let it close the question, because he was right. Afterward was a different problem. The problem in front of her was a man in a room upstairs with 3.5 millimeters of midline shift and a surgical team arriving in less than 3 hours, who needed to understand what they were walking into. They took the elevator to the 3rd floor. The neurology consultation room, adjacent to 318, had been converted into a staging area. Reeves had apparently arranged this in the same 10 minutes. Jictus, Nora had used to change, which told her something about how the colonel's team operated. There was imaging on a portable display, a second tablet, with Steele's full military medical file, the actual file, not the civilian admission paperwork, and 2 chairs pulled up to a small table. Steele was still in 318, now with an IV line carrying a mannitol drip to manage intracranial pressure while they waited for the surgical team. Dr. Felt had been formally moved off the case and replaced by the neurology consult, who had been called in from the 4th floor, a woman named Doctor. Patricia Sung, who had the focused, rapid manner of someone who had been handed a situation mid-development and was moving fast to get current. Sung looked at Nora when she came into the consultation room and said, without introduction, "You're the one who flagged the symptom pattern." "Yes," Nora said. "The CT confirms subdural acute on chronic, right temporal, with posterior extension." Sung pointed at the imaging on the display. "Posterior margin is my concern. Tell me what you know about the original injury site." Nora pulled up the military file on the second tablet and found the field hospital report from 18 months ago. The report was sparse field documentation usually was, but it included the shrapnel entry points and the initial imaging notes. She read the relevant section aloud, then looked at the imaging again and mapped the original injury trajectory against the current hematoma boundaries. "The original blast disrupted the tissue along this margin," she said, tracing the line on the display without touching it. Field imaging was clean for hematoma at the time, which is consistent with a slow venous bleed that hadn't yet accumulated enough volume to show. But the venous structures in this region, specifically the vein of Labbe and the adjacent drainage anatomy, were in the direct disruption zone. There's a meaningful probability that those structures are compromised even where the imaging looks intact. Sung was looking at the display with the specific attention of someone absorbing information that is changing their surgical plan in real time. If the vein of Labbe is compromised, and Trent uses a standard temporal craniotomy approach, he'll be working directly over a structure that may not tolerate the retraction, Nora said. If it tears during the approach, the bleed becomes venous at volume, and the situation changes significantly. "What's the alternative approach?" Sung asked. "Modified lateral position, more posterior entry point, staying above the drainage anatomy rather than crossing it. It adds time to the exposure, but keeps the critical structures out of the primary working corridor." Sung was quiet for 4 seconds, which in this context was a long time. "You've seen this before." "I've managed a version of it," Nora said, which was accurate and said everything it needed to without saying more. "In what setting?" Nora looked at her steadily. "A setting without a CT scanner or a surgical suite." Sung held her gaze for a moment, and something passed across her face that wasn't quite the full picture of what she was thinking, but was adjacent to it. She looked at Farron, who was standing near the door. He gave a single, small nod that carried more information than most paragraphs. Sung looked back at Nora. "I want you in the room when Trent arrives," she said. I'll handle the clinical introduction. That was when the door opened and Preston Marlowe walked in. He was not supposed to be here. The meeting with Duro was supposed to have kept him occupied for another 20 minutes, and the fact that it hadn't meant either that the meeting had ended early or that someone had told him what floor to come to, and Nora's assessment of the situation suggested it was more likely the latter. He came through the door with Diane Fuchs behind him, again, and a third person. She didn't recognize a man in a suit, not medical staff. Administrator in his eyes found Nora immediately with the targeted directness of someone who has been building toward a confrontation and has now arrived at it. This is the restricted consultation suite for an active military patient case, Farron said from the door. His voice was even. Access is being managed by Army Medical Command Liaison Protocol. I'll need to see your authorization before we continue. Marlowe looked at Farron the way he looked at anything that didn't fit his established framework, a brief recalibration, then dismissal. I am the chief of trauma surgery at this facility, and I have administrative standing in every department. This patient is under Army Medical Command jurisdiction, Farron said. Your facility's administrative standing doesn't extend to override a formal military consultation protocol. This nurse, Marlowe, pointed at Nora, not with the imprecision of anger, but the deliberate specificity of someone making a legal distinction, is on administrative leave and has had her contract terminated pending end of week. She has no standing in this room. Her standing in this room is established by a formal Army Medical Command consultation request, Farron said. Submitted at 1420 and acknowledged by your administration at 1458. The administrator in the suit, who had come in with Marlowe, shifted his weight slightly. That shift told Nora he had known about the acknowledgement and had not fully briefed Marlowe on its implications before they walked in, which was going to be a problem between those two men later, but was right now simply useful information. Preston. Sung's voice was quiet and direct. She didn't raise it. I need the room. The surgical team arrives in 2 hours and 20 minutes, and I have a pre-op consultation to complete. Marlowe looked at her. Sung was not in his chain of command. She was neurology. He was trauma surgery, and they were parallel rather than hierarchical. But the administrator shifted his weight again, and Marlowe read that correctly, and the calculation behind his eyes moved through several positions before landing on the one that allowed him to leave without it reading as a retreat. This conversation is not finished, he said, directed at Nora. I know, she said. He left. Diane followed. The administrator paused in the doorway for a moment, looked at Farron, and then left without speaking, which was a decision that would cost him later, but was the right red of the room right now. The door closed. Sung exhaled once through her nose. Let's keep moving, she said, and turned back to the imaging. The next 2 hours were the kind of dense, technical work that Nora could do in a state that was simultaneously high alert and perfectly focused, the two things not contradicting each other, but operating in the specific combination that she had found in her experience, was only accessible when the stakes were real enough that there was no room for anything extraneous. She and Sung went through the imaging together in granular detail, mapping the hematoma boundaries, discussing the venous anatomy considerations, building the surgical approach argument that Sung was going to present to Trent when he arrived. Calloway contributed from the military medical file specifics about the original injury presentation, the field treatment, the follow-up imaging that had cleared Steele for return to duty. Reeves documented everything. At one point, Nora stepped out and went to 318 to check on Steele. He was awake, less sharp than he'd been. That morning, the mannitol was managing the pressure, but not eliminating it, and the cognitive edge she'd seen in his eyes during their first conversation had blurred slightly at the margins. Trent coming from Billings? He asked. His voice was slower. 2 hours, she said. She checked his pupils with a penlight equal, still reactive, right slightly slower than left, which was consistent with the imaging. "How's the headache?" 7 out of 10, he said. It was a 4 this morning. She noted that. The escalation over the course of a day was not unexpected given the acute on chronic nature of the bleed. But it was a reminder that the window she had been thinking about in the abstract was concrete and narrowing. Anything new? Vision? Weakness? Vision's been blurring on and off for the past hour. Right eye. She documented it. I'll update Dr. Sung. His voice stopped her at the door. She turned. He was looking at her with the particular directness of a man who has spent a career in situations where vagueness was a liability. Farron told me what you know, what you've done before. Not the details, just what it means. She waited. I want you in that operating room, he said. I'll be there, she said. She went back to the consultation room and updated Sung on the symptom progression. Sung modified one element of the pre-op plan in response, adjusting the mannitol dosage and adding a second IV line in preparation for the surgery. She did it efficiently and without drama, which was the right response, and Nora registered it as a reliable data point about Sung's character. Dr. Marcus Trent arrived at 4:53, 40 minutes ahead of schedule, which meant he had pushed the drive from Billings hard. Came in with 2 residents and a scrub tech, and he had the focused, slightly compressed energy of a surgeon who has been briefed on a case mid-transit and is still processing the specifics, while the rest of him is already moving toward the operating room. He was younger than Nora had expected, early 40s, lean, with the particular restlessness of someone who thinks fastest when their hands are doing something. He reviewed the imaging in 4 minutes, asked Sung 3 sharp, specific questions about the posterior margin, and then looked at Nora for the first time. You're the clinical consultant, he said. Nora Voss. Patricia says you have blast injury hematoma experience. Specifically, posterior temporal presentation. Yes, she said. Where she had known the question was coming and had decided, sometime in the previous 2 hours, exactly how she was going to answer it. Forward operating environments. Multiple cases over a 6-year period. Trent looked at her for 3 seconds. He was running the arithmetic 6 years. Forward operating environments. The specific procedural knowledge that Sung had apparently characterized as relevant enough to request her presence. His eyes moved briefly to Farron, who was standing near the window, and then came back to Nora. Walk me through your concern about the venous anatomy, he said. She pulled up the imaging on the display and walked him through it. She was precise and economical. The location of the original injury, the probability of venous architecture, compromise along the posterior margin, specific risk point in a standard temporal craniotomy approach, the modified entry point she had discussed with Sung. Trent listened without interrupting, which was either the sign of someone genuinely absorbing what they were hearing or someone who had already decided their position and was waiting for her to finish. Couldn't tell which, and she didn't try to, because that wasn't her job. Her job was to give him the information clearly enough that ignoring it was a choice he would have to make consciously. When she finished, he was quiet for a moment. Then he looked at Sung. She's right about the drainage anatomy risk. I've been thinking about the posterior margin since Patricia called me. A pause. The modified approach adds 20 minutes to the exposure. 20 minutes is recoverable, Sung said. An uncontrolled venous bleed is not. Agreed. He looked back at Nora. I want you scrubbed in. Not hands-on, you're observing and advising. If something develops in the posterior corridor that you've seen before, I need to hear it immediately. She had not expected him to agree that quickly. She had prepared for resistance, for the territorial's response, that surgeons sometimes produced when a nurse was positioned as a knowledge resource rather than a support role. She recalibrated in approximately 1 second. Understood. We're wheels up in 40 minutes, he said, meaning the operating room. He was already moving toward the door. Someone get me the full military file. Reeves extended the tablet before Trent finished the sentence. Preparation for surgery was its own controlled cascade pre-op checks, anesthesia consult, the operating room being configured for the modified lateral position that the adjusted approach required. Nora scrubbed alongside the surgical team, went through the standard preoperative protocol, and stood at the instrument table while the anesthesiologist, a careful woman named Dr. Voss, ran through the induction sequence with Steele, who was conscious until the last moment, and who, in the last moment before he went under, looked across the room and found Nora's eyes with the specific deliberateness, the final assessment, of someone making a final assessment of whether the person they're counting on is actually going to be there. She held his gaze until the anesthesia took him. The surgery began at 6:17. Trent worked with the efficient confidence of someone who had done this enough times that the mechanics were automatic, which freed his attention for the non-automatic elements, the specific anatomy of this patient, the modifications to the standard approach, the running communication with Sung and the two residents who were managing the retractors and monitoring the field. Nora stood at the edge of the active corridor, watching, saying nothing unless something required it. The first 40 minutes were clean. The exposure proceeded along the modified line they had planned, staying above the critical venous drainage, the hematoma coming into view on schedule. Trent evacuated the primary collection with the methodical patience of someone who knows that speed in this specific moment is the wrong variable to optimize. The complication arrived at minute 47 in the form of a small but persistent bleed from the posterior margin of the surgical field that did not respond to the standard hemostatic measures the way it should have. "I've got a bleeder that placed the posterior edge," Trent said, his voice controlled, not stopping with pressure. Nora looked at the field. She had seen this precise configuration, not often, but enough. The bleed was coming from a bridging vein that had been disrupted by the original injury and had been under precarious tension ever since, held in place by the fibrous tissue that formed around it during the 18 months of partial healing. Craniotomy had released that tension, and the vein was now behaving accordingly. "It's a bridging vein," she said, disrupted at the original injury site. It won't respond to pressure because the wall integrity is compromised along its entire accessible length. Trent looked up briefly. "Options. Bipolar coagulation along the length before you try to control the terminus," she said. "If you go for the terminus first, you risk avulsion." A half-second pause. "Show me the line." She moved one step closer to the field and traced the path in the air above the surgical site, not touching, never touching, but precise enough that Trent could map it onto what he was seeing. He looked at her indication, looked at the field, and then looked at his resident. "Polar. Start proximal." The coagulation took 4 minutes. The bleed slowed, consolidated, and stopped. Trent held the position for 30 seconds, watching. The field stayed dry. "Good call," he said quietly, to no one in particular, or possibly to Nora, and moved on. The remainder of the surgery ran without significant complication. The hematoma was fully evacuated. The closure proceeded along standard lines. At 8:41, Trent stepped back from the table and said, "Close," to his resident, and the last phase began. Nora stepped back from the corridor and stood near the instrument table. Her hands were steady. She was aware of Voss running the postoperative vitals assessment, of the quiet, efficient communication between Trent and the residents, of the specific quality of the room when a surgery has gone the right way, not celebration. Nothing as loose as that, but a settling as release of the particular tension that accumulates when the outcome is still uncertain and dissipates when it isn't anymore. She was aware of something else, too, something outside the operating room. Through the small window in the OR door, she could see the scrub corridor. And in the scrub corridor, visible through the glass, was Preston Marlowe. He had not scrubbed in. He was standing in the corridor in his street clothes, looking through the window into the operating room, and the expression on his face as he looked at the surgical field, at the closed incision, at Trent stepping back, at the resident beginning the closure, was not the expression of a man processing a successful outcome. It was the expression of a man processing a rearrangement of the world that he had not authorized and could not reverse. His eyes moved from the surgical field to Nora. She looked back at him through the glass. She didn't look away. She didn't arrange her expression into anything not particular, not defiance, not satisfaction, just the same steadiness she had brought into every room at Kettner Valley Medical Center since the first morning she walked through its doors. Steadiness of someone who knows exactly what they did and why they did it, and is not interested in performing either regret or vindication. Marlowe held her gaze for 3 seconds. Then he turned and walked away down the corridor, and she watched him go with the specific attention of someone who understands that a man walking away from a window is not the same thing as a man who is finished. Steele was moved to the ICU at 9:15. His post-operative vitals were within acceptable parameters. The first neurological check, performed by Sung 30 minutes after transfer, showed improved responsiveness on his side and a reduction in the headache score to a 3, which was consistent with successful hematoma evacuation and the early normalization of intracranial pressure. Trent found Nora outside the ICU at 9:40, where she was standing at the corridor window, writing her observation notes on the case. Stopped beside her without preamble. "The bridging vein call saved the surgery," he said. "I want you to know I'm aware of that. You would have caught it," she said. "Maybe," he said, not as fast. He paused. "Farron told me after we closed. Who you are, what your background actually is." She kept her eyes on the notes. "I know he did. How long have you been hiding it?" She was quiet for a moment. "I wasn't hiding it. I was done with it." Trent considered that. "And now?" She looked up from the notes and through the window at the ICU, where Steele was visible in the third bay, monitors running, Sung reviewing the post-op chart. She thought about the desk in the administrative wing and the insurance authorizations, and the formal termination notice that Diane Fuchs was going to send by end of day. She thought about Marlowe at the corridor window and the way he'd turned and walked away. "Now, I'm not sure what I am," she said, which was the first completely honest answer she had given anyone at Kettner Valley Medical Center since she arrived. Trent nodded, as if that was a reasonable response to a complicated situation, which it was. He said good night and walked toward the elevator, and Nora watched him go and then looked back at her notes and was about to finish the final line when her phone buzzed. It was a number she didn't recognize, not internal, not military, a Montana area code she didn't have saved. She answered. "Is this Nora Voss?" A woman's voice. Careful, deliberate, the pacing of someone reading from something prepared. "Yes," Nora said. "My name is Sandra Pruitt. My husband Dale was brought into your hospital 2 weeks ago. Construction accident. They said a nurse saved his life, stopped him from dying in the trauma bay from something the doctors missed." Nora stood very still. "I've been trying to find out who it was," the woman continued. "The hospital wouldn't tell me. But someone gave me your name tonight." Someone. Nora turned that word over. Someone at Kettner Valley had given this woman her name tonight. After the surgery, after Marlowe had stood at the window and walked away. "Mrs. Pruitt," Nora said, "how can I help you?" "I just wanted to say thank you." The woman's voice was steady, but barely. "He's home. He's okay. Our kids still have their father." A pause. "I wanted to know who to thank." Nora stood in the corridor, outside the ICU with the phone in her hand and the post-operative notes in the other, and the specific wait of 11 days at Kettner Valley Medical Center sitting somewhere in her chest. She thought about how you answer something like that, when the honest answer is, "I almost didn't do it, and I'm not sure what happens to me tomorrow, and I don't know yet if I made the right call or just the only call I was capable of making." "I'm glad he's okay," she said, "because that part At least, it was simple. She ended the call and stood in the quiet of the corridor for a moment longer. The ICU hummed behind the window. The hospital was in its late evening register, reduced foot traffic, lower lights in the non-critical areas. The specific sound profile of a building that never fully sleeps but does something in the vicinity of it. Her phone buzzed again. This time it was a text from Farron, Board of Inquiry convening tomorrow morning. Administration, Army Medical Command Liaison, Department Heads, 800. You will be asked to attend. She read it twice. Set the phone in her pocket. A Board of Inquiry. Not a conduct review managed by Marlowe at his own pace, an actual board, with Army Medical Command in the room, convening at 8 in the morning. Which meant someone tonight had decided that the question of what had happened at Kettner Valley Medical Center over the past 11 days was no longer a matter to be settled internally and quietly. She didn't know yet whether that was good for her or not. Expected it was both in different proportions that she couldn't calculate from where she was standing. What she knew was that tomorrow at 8 o'clock, Preston Marlowe was going to sit in a room where his authority was not the organizing principle and answer questions about 11 years of running a department the way he had run it. And the person who had triggered that room being convened was a float pool nurse he had terminated 2 hours before she saved a general's life. Put the phone away, picked up her notes, and walked toward the elevator. Behind her, the door to the ICU opened, and Sung stepped out into the corridor with a tablet in her hand and an expression that meant she had just reviewed the most recent post-op check, and the numbers were moving in the right direction. He's asking for you, Sung said. Nora turned. The general? He's alert, coherent, asking for the nurse. His expression held something that was not quite a smile, but was close enough to its functional equivalent that the difference didn't matter. His words were, the nurse who actually looked at me. Nora looked at the ICU door for a moment. Then she walked back toward it, pushed it open, and went in. Steel was propped at 30 degrees when Nora came through the ICU door, which was the correct post-operative position for intracranial pressure management, and told her that whoever had set him up had done it right. The monitors beside his bed showed a heart rate in the low 60s, blood pressure at a reasonable post-op level, oxygen saturation clean. The right side of his head was bandaged from the closure, and there was the particular pallor that comes after general anesthesia and significant blood loss. But his eyes were open and tracking, and when she came to the side of the bed, they found her with the same directness they'd had that morning, which was the most important thing she'd seen since she walked through the door. You stayed, he said. His voice was rough from the intubation, the words slightly slower than they'd been before surgery, which was expected and would resolve. I said I would, she said. She checked his pupils, with the penlight equal, both reactive, the right side responding at the same speed as the left now, which was not a small thing. She noted it in her observation record, without comment. Did Trent do what you told him? He did his job, she said. I gave him information. He made the decisions. Steele was quiet for a moment, processing that, with the slightly delayed rhythm of someone whose brain was still recalibrating to the absence of the pressure that had been building inside it for 3 weeks. Ferran told me about the Board of Inquiry, he said. Tomorrow morning. I know. He also told me what that Dr. Marlowe did to you. The administrative leave. The termination. She set the penlight back in her pocket. That's a separate issue. It's not separate, he said. The slowness in his speech didn't touch the precision of what he was saying. I've been in organizations my entire adult life, Voss. I know exactly what a man like that does and why he does it, and what it costs the people around him. A pause, effortful. I'm going to be asked to give a statement to the board. You should rest, she said. I'll rest after. He looked at her steadily. I'm going to tell them what I know. About the admitting diagnosis. About what you found and how you found it, about the fact that this hospital had me on a cardiac protocol for a condition I didn't have, while a nurse on administrative leave was the only person in the building who looked at me like a complete case. She didn't try to talk him out of it, because it wasn't her place to, and because he was right, and because the part of her that had been swallowing the same kind of institutional dismissal for 11 and for years before, that was not going to pretend otherwise. Get some sleep, General, she said, and meant it as the practical instruction it was. She left the ICU at 10:20 and drove back to the room on Kettner Valley Road in the dark, ate something she didn't taste, and sat at the kitchen table for an hour, running through what tomorrow's Board of Inquiry was likely to look like, and what she was going to say when she was asked to account for 11 days that had started as a quiet transfer posting and ended with a military patient in the ICU and a chief of trauma surgery standing in a corridor window watching the outcome of a decision he'd tried to prevent. She slept 4 hours. It was enough. She had functioned on less. The Board of Inquiry convened in the 4th floor conference room at 8:02, which meant it started 2 minutes late, which, in Nora's experience, meant someone had arrived slightly behind schedule, and the person running the meeting had waited for them rather than starting without them, which was a small data point about how the room was going to be organized. She found out when she arrived at 7:50 and was shown to a waiting area outside the conference room that someone who had caused the 2-minute delay was Colonel Farron, who had been on the phone with Army Medical Command until 8:01 and had walked in, still closing the call. The board was composed of 7 people. Dr. Annette Duro, Chief of Medical Staff, seated at the head of the table. Farron on her left, with Reeves beside him, taking notes on the tablet. 2 hospital administrators, the man in the suit from yesterday, whose name turned out to be Gerald Prudhomme, and a woman named Catherine Solis, who was the chief operating officer and who had flown in from the regional administrative office in Great Falls that morning, which meant someone had called her last night, and she had considered what she was told important enough to drive to the airport at 6 in the morning. Dr. Patricia Sung, representing the neurology consult. And at the far end of the table, Preston Marlowe, in his white coat, seated with the particular stillness of someone who has decided that stillness is the correct strategic posture for this room. Nora was brought in at 8:15, after the board had been in session for 13 minutes without her. She didn't know what had been said in those 13 minutes. She could read the room well enough to know that whatever it was had not been uniformly comfortable for everyone present. Prudhomme had the look of someone who had recently been given information he wished he'd had earlier. Solis was watching Marlowe with the focused, assessment-oriented attention of someone who has not yet decided what she's dealing with, but is actively working on it. The Dutch psycholically, professionally. Duro ran the session with the efficient neutralities of someone who has run difficult institutional meetings before and knows that the most important thing she can do is keep the framework clear enough that the facts don't get lost in the process. Nora was asked to give a full account of her 11 days at Kettner Valley, beginning with intake, through the Garrett observation, the Pruitt trauma bay intervention, the administrative leave, the Steele consultation, the surgery. She gave it in the same clean, sequential language she used for clinical documentation, without editorializing, without framing it as a grievance, because that was not what it was. It was a record of events. She let the events carry the weight. Marlowe listened to the whole thing without interrupting, which she recognized as a decision rather than a response. When Duro asked him to respond to Nora's account, he did so methodically, each of his interventions framed as adherence to protocol, the administrative leave characterized as a standard response to unauthorized department access, the termination described as a proportionate consequence for repeated boundary violations by a nurse whose posting was temporary and whose conduct had created institutional risk. He was good at it. She had expected him to be. what he was not good at, what no one is good at, when they've spent 9 years building a system that depends on the people inside it, not talking to the people outside. It was the moment when the outside started talking on its own. Solis spoke for the first time at 8:47. Dr. Marlowe, I've been reviewing the conduct file you submitted regarding Nurse Voss. The file references protocol violations in the trauma bay and an unauthorized patient contact in room 318. It does not reference the clinical outcomes associated with either incident. A pause that was not casual. The patient involved in the trauma bay incident, Dale Pruitt, was discharged without complication after treatment for a tension pneumothorax that was identified by Nurse Voss and confirmed by Dr. Sandoval. The patient in room 318 underwent successful neurosurgery last night for a subdural hematoma that had not been identified under the admitting diagnosis. Patients are alive and recovering. She looked at him steadily. Conduct file characterizes both incidents as protocol violations. It does not mention that in both cases, the clinical observations that triggered Nurse Voss's actions were correct. Protocol exists independently of outcome, Marlowe said. Correct observation, delivered through improper channels, still represents a procedural failure that which of your nurses should have caught the tension pneumothorax? Farron asked. His voice was conversational. It was the most dangerous kind. Marlowe looked at him. My team was managing a complex, multi-system trauma presentation. The pneumothorax was in the room for approximately 7 minutes before Nurse Voss identified it, Farron said. I'm asking which member of your team was responsible for monitoring for that complication and what prevented them from catching it. The room was quiet in the specific way that rooms are quiet when a question has been asked that everyone present knows does not have a good answer. As Marlowe said, trauma management involves prioritization of competing clinical demands, and Nora watched Solis write something on the notepad in front of her and underline it. The board session ran until 10:15. By the end of it, 3 things had been formally established in the documented record: that Nora's clinical observations in both patient incidents had been accurate and clinically significant, that her conduct file, as submitted by Marlowe, did not accurately represent the full context of either incident, and that Army Medical Command was formally requesting a review of the administrative actions taken against her during the period of her consultation, involvement with the Steele case. That last point was Farron's delivered in the flat, careful language of a formal institutional request, and it landed in the room with the weight of something that couldn't be argued with on the grounds of protocol, because it was at what's a protocol from an authority that outranked the one that had generated the original conduct file. Marlowe's face when Farron finished speaking was the face of a man who has played a particular game for 9 years and has just discovered that the board he's been playing on has edges he didn't know were there. Nora was excused at 10:15 and returned to the waiting area while the board continued in closed session. She sat in a chair outside the conference room and read through her observation notes from the previous night's surgery, correcting 2 minor documentation details she'd flagged during the night. She was mid-sentence when the conference room door opened and Sung came out. Sung sat down in the chair beside her, not across from her. Beside her, which was a physical choice that communicated something without requiring words. Solis asked Duro to pull the department complaint records for Marlowe's tenure. Sung said, keeping her voice low. Going back 5 years, Nora looked at her. There are 14 formal complaints from nursing staff, Sung said. 11 were closed without action. 2 resulted in written warnings that were subsequently removed from his file after review. 1 is still technically open from 18 months ago. She paused. 3 nurses left this hospital in the past 4 years, specifically citing the department culture. One of them filed an exit interview that described a pattern of systematic intimidation of nursing staff who raised clinical concerns. Nora sat with that for a moment. 14 complaints. 11 closed without action. She thought about Diane Fuchs and the particular quality of Diane's expression when she delivered Marlowe's instructions, not agreement, exactly. Compliance. The specific compliance of someone who has learned that the cost of not complying is higher than the cost of going along and has made that calculation so many times that it no longer feels like a calculation. Who pulled the records? Nora asked. Solis asked for them directly, Sung said. Duro didn't object, which means she either already knew about them or decided in the past 2 hours that she needed to. The door opened again, and Prudhomme came out, looked at both of them without speaking, and walked toward the elevator with the gait of a man carrying something he wishes he could put down. Nora watched him go. The COO flew in from Great Falls this morning, Nora said. Yes, Sung said. Someone called her last night. After the surgery. Before the board was formally convened. Sung was quiet for a moment. Duro made 3 phone calls after she left the ORR observation corridor at 9:30, she said, with the careful tone of someone relaying information they've assembled from adjacent sources. I don't know who she called, but one of those calls was 42 minutes long. 42 minutes was not a logistical call. 42 minutes was a conversation about something that required genuine deliberation. Nora thought about Duro cutting a meeting short to come out and hear a patient safety concern from a float pool nurse she'd never met. She thought about the way Duro had said, I understand the implication of what you're describing, and then told her to go back to her assignment, not dismissal. She understood now. Management. The specific management of someone who needed time to assess before acting and who had used that time. The board session ended at 11:40. Duro came out last, and she came to the waiting area and stood in front of Nora with the expression of someone who has arrived at a decision and is not looking for input on it. The board has recommended a full review of your conduct file, she said. Pending that review, the administrative leave and termination notice issued by Dr. Marlowe are suspended. You are reinstated to active nursing duty, effective immediately. She paused. The board has also recommended an independent review of the trauma surgery department's complaint history and departmental conduct practices to be conducted by an external panel appointed by the regional administration. Marlowe? Nora said. Dr. Marlowe has been asked to step back from departmental management responsibilities during the review period. Duro's voice was precise and entirely without satisfaction, which was the correct register for a chief of medical staff delivering institutional decisions. His clinical privileges remain intact. His administrative authority is suspended pending the review outcome. Nora sat with that, suspended. Not terminated, not formally sanctioned, suspended. Pending review, which meant the institution was moving carefully, which was both the right approach and a reminder that institutions moved at their own pace for their own reasons. How long does the review take? She asked. External panels typically run 6 to 8 weeks. Duro looked at her with the directness of someone deciding how candid to be and landing on candid. What the complaint history shows is significant. Nurse Voss. Panel will have full access to it. The outcome of the review is not something I can predict, but the record that exists is thorough. She left. Nora sat in the chair for another minute, alone in the waiting area, looking at the closed conference room door. 6 to 8 weeks. Marlowe running his department under suspension, his administrative authority gone. An external panel working through 14 complaints and 3 nursing departures, and an exit interview that described systematic intimidation. That was not nothing. That was the beginning of something that had been a long time coming and had arrived, because a float pool nurse with a Billings transfer file had spent 11 days doing her job in a hospital where the expected response to that was administrative leave and a termination notice. She wasn't finished processing it when her phone rang. Soledad. They told us, Soledad said without preamble. Marlowe's out of department management. There's a review. A pause. The floor is trying to figure out what to say. The other half already knows. What do you know? Nora asked. I know that every nurse on this floor has a story about Marlowe that they've never put in writing because they didn't think it would matter. Soledad's voice had a quality in it that Nora hadn't heard before, not anger, but something that had been held under pressure for long enough that the release of the pressure changed its sound. They might put them in writing now. That's their choice to make, Nora said. Yeah, a pause. Are you coming back in? This afternoon, Nora said. She was at the nursing station on the second floor by 1:30, back in her scrubs, running through a shift handover with the nurse she was relieving. The floor felt different than it had on any of her previous 11 days, not dramatically, not with any visible ceremony, but differently. Staff members who had moved past her without acknowledgement the first week made eye contact. A resident she'd never spoken to directly stopped her in the corridor to say he'd heard about the steel tail surgery and asked a specific question about blast injury presentation that she answered in 3 sentences. Russell, the night nurse who noticed everything and said very little, looked up from his chart when she passed the station and a single nod that gave her the weight of someone who keeps long and accurate record. She managed her afternoon patients, completed her documentation, and was finishing a medication reconciliation at 3:50 when Diane Fuchs appeared at the nursing station. Diane stood at the counter without speaking for a moment, which was unusual for her. She had the specific look of someone who has been deciding whether to have a conversation and has arrived at the decision, but not yet at the words. I signed the termination paperwork, Diane said finally, this morning. Before the board convened, Nora looked at her. I signed 11 complaint closure forms over the past 4 years, Diane said, when Marlowe said to close them. The corridor was quiet around them. Nobody at the adjacent workstations was visibly listening, which didn't mean they weren't. Did you agree with closing them? Nora asked. Diane was quiet for a moment that had the quality of something being weighed carefully. No, she said. Not all of them. She set a folder on the counter between them, and Nora looked at it without picking it up. That's my own documentation. The notes I kept when I processed the complaints. I wrote everything down, even when I was told the files were closed. A pause. I'm giving it to the review panel. Nora looked at the folder, then at Diane. Diane's expression was not apologetic exactly. It was the expression of someone doing a correct thing late, which is different from an apology, but is its own kind of statement. That took something, Nora said. It took 11 days of watching you work, Diane said, which was as close to direct acknowledgement as Nora suspected Diane Fuchs had come in a long time. She picked up the folder and walked away down the corridor, and Nora watched her go, and thought about what it costs people to survive inside systems built by people like Marlowe, and how the cost is different from the outside than it looks. The next escalation came at 4:20, and it came from a direction Nora hadn't fully anticipated. The external review panel had been announced to staff via internal memo at 2 o'clock. By 3, 2 of the nurses who had left Kettner Valley in the past 4 years had been contacted by the panel's intake coordinator. Duro had apparently moved on the panel formation with more speed than 6-8 weeks suggested, which meant she had possibly started making calls before the board session formally concluded that morning. Mag. By 4, the COO's office had received a call from the Montana State Board of Nursing, which had apparently been monitoring the Kettner Valley situations through a channel Nora didn't fully understand, but suspected was connected to the exit interview filed 18 months ago that was still technically open. She found out about the state board call from Sung, who appeared in the second-floor corridor at 4:20 with the specific expression of someone carrying information that has just changed the shape of the situation. The state board is opening a parallel inquiry, Sung said, keeping her voice low. Independent of the hospital's internal review, they have jurisdiction over Marlowe's medical license. Nora stopped walking. His license. A state board inquiry into professional conduct can result in license restriction, suspension, or revocation, Sung said. It's independent of what the hospital does. Even if the internal review goes conservatively, the state board operates on its own timeline and its own standards. She paused. The exit interview from 18 months ago was filed with both the hospital and the state board. The hospital sat on it. The state board apparently did not. State board had been waiting. That was what Sung was telling her in the careful language of someone who works inside an institution and has to be precise about what she says in its corridors. The state board had had the exit interview for 18 months and had been watching, and what had happened in the past 48 hours at Kettner Valley Medical Center had given them the event sequence they needed to move. Nora stood in the corridor and thought about Preston Marlowe in his white coat at the end of the board table that morning, delivering each of his responses in the measured, protocol-grounded language of a man who understood institutional process well enough to use it as a shield. He had used it for 9 years. He had used it on 14 complaints and 3 departing nurses and Diane Fuchs's locked-away documentation and whatever else lived in the record that the external panel was now going to access. The shield had held for 9 years because the challenges to it had been internal. A nurse filing a complaint that went to Marlowe's own administration. An exit interview that went to the hospital first. Everything inside the system he had built, processed by the system he had shaped, closed or minimized or filed away by people who had learned that not closing it cost more than closing it. The state board was not inside his system. He doesn't know yet, Nora said. The notification goes to him formally at 5 o'clock, Sungson said. Nora checked her watch. 22 minutes. She went back to her patients. Completed a wound assessment, updated 2 charts, responded to a call light from a post-surgical patient who needed her pain medication timing adjusted. She did each of these things with full attention, because the patients in front of her were the patients in front of her. And what was happening 4 floors away in the administrative suite was happening whether she thought about it or not. At 4:58, she was at the nursing station writing up the pain management adjustment, when she heard it not loud, not dramatic, but audible through the door of the stairwell that opened onto the second-floor corridor. Footsteps going down, fast, uneven, not the measured pace of a man who has decided that stillness is his correct strategic posture. Footsteps of someone who has just been handed something they hadn't fully prepared for and is moving in response before they've finished processing it. She didn't look up from the chart. At 5:15, Soledad sent her a message. Marlowe left the building. His car is gone from the physician lot. Nobody's seen Diane. Nora read it and set the phone down and finished the chart entry she was working on. She saved it, closed the window, and sat for a moment at the nursing station, in the specific quality of quiet that settles after something long in motion has finally reached its next stage. The floor ran its evening protocols around her, shift changeover at 6, the incoming nurses getting their briefings, the particular rhythm of a hospital moving from its afternoon register into its night one. She completed her handover notes for the oncoming nurse, flagged 2 patients for close monitoring overnight, and was signing off on her timesheet when Russell appeared at the station beside her, chart in hand, with the expression of someone who has decided that the thing he's been composing internally for several hours is ready to be said. The nurses who left, he said. The 3 in the past 4 years. He was looking at the chart in his hand rather than at her, which was fine. I worked with all of them. 2 of them were the best nurses on this floor. He paused. One of them filed the complaint that's still open. I know, Nora said. She has a nursing job in Idaho now, he said. She told me once she left, because she didn't think it was ever going to change. Nora finished signing the timesheet. Maybe she was right about the timing, she said, not about the direction. Russell was quiet for a moment. Then he nodded in the way that people nod when something has been said that covers what needs to be covered without requiring elaboration, and went back to his chart. She was at the elevator, coat in hand, when her phone buzzed. Not Soledad this time, not Farron, a number she hadn't seen before, with a Montana area code, and when she answered it, there was a 2-second pause before the voice came through. Nurse Voss, a woman's voice, older, careful. My name is Loretta Vane. I was a charge nurse at Kettner Valley Medical Center until 14 months ago. A pause. I'm the one who filed the exit interview. Nora stood at the elevator with her coat over her arm and listened. I heard what happened this week, Loretta said. Someone on staff called me. I've been following it. Her voice had the quality of someone who has rehearsed what they're about to say and is deciding mid-delivery how much of the rehearsed version to actually use. I need to tell you something that isn't in the exit interview. Something I didn't put in writing because I couldn't prove it and I was afraid of what proving it would cost me. The elevator arrived. Nora didn't get on it. She stepped to the side and let the doors close. What is it? She said. The complaint that was filed 2.5 years ago, Loretta said. The one that resulted in a written warning for Marlowe that was subsequently removed from his file. Removal didn't happen through normal administrative channels. A pause. I saw the paperwork. Someone above department level signed off on the removal without going through the standard review committee. I reported it internally and was told the process had been followed correctly. 3 months later, I resigned. Nora was very still. Who signed the removal, she said. Loretta said a name. It was not Diane Fuchs. It was not an administrator Nora had met or heard of in 11 days at Kettner Valley. It was a name that, when she ran it against everything she knew about the hospital's structure and the board's composition and the people in the conference room that morning, landed in a place that changed the geometry of what she was looking at in a way she had not been prepared for. You need to give that to the state board, Nora said. Not the hospital panel, the state board. I know, Loretta said. I called them at 4:30. They're sending someone tomorrow. A pause. I wanted you to know before it becomes public, because you're the reason I made the call. The second-floor corridor was empty around her. The elevator gone, the nursing station quiet at the end of the hall. Through the window at the far end, the Montana dark was coming in early, the way it did in late October. The mountains already swallowed by it. The lights of Harlow Creek, visible in the low distance, like a circuit board, laid flat against the valley floor. Nora stood with the phone in her hand, and the name Loretta had given her sitting in her chest like a coal that was still deciding whether it was going to burn. The person who had signed the removal of Marlowe's warning from his file was not a middle-level administrator acting without authority. They were not someone who could be explained as a single bad actor making a poor judgment call in isolation. They were someone whose position at Kettner Valley Medical Center meant that what Loretta was describing was not a procedural failure. It was a decision made by someone with enough standing to make it stick and enough interest in making it to act on that standing. And that person had been in the conference room this morning. The name Loretta had given her belonged to Gerald Prudhomme. Nora stood in the empty corridor and ran it back through everything she had observed in the conference room that morning. Prudhomme arriving with Marlowe sitting slightly behind him, shifting his weight when Fern mentioned the Army Medical Command acknowledgement. She had read that shift as a man who hadn't fully briefed his colleague. She had been right about the what and wrong about the why. Prudhomme hadn't failed to brief Marlowe because he was disorganized. He had positioned himself beside Marlowe because proximity to Marlowe's defense was the safest place to be while the board was still in session and the shape of the outcome was still unclear. He had been managing his own exposure, not Marlowe's. Called Farron. He answered on the second ring. She told him what Loretta had said, including the name, in the same sequential, unembellished language she used for clinical reporting, because the information was what mattered, and framing it as anything other than informations would slow down what needed to happen next. Farron was quiet for 4 seconds after she finished. Does Loretta Vane have documentation? She says she saw the paperwork. She may have retained copies. She's speaking to the state board tomorrow. I'm going to make a call, he said. Don't go home yet. She waited in the second-floor corridor for 18 minutes. At the end of those 18 minutes, Farron called back and said 3 sentences. The state board investigator assigned to the Kettner Valley inquiry had been briefed on the Prudhomme information. Duro had been contacted and had asked for an emergency meeting with the COO, Catherine Solis, tonight, and Prudhomme had been informed, as of 40 minutes ago, that his administrative access to hospital personal files had been suspended pending a records integrity review. The records integrity review. That was the language institutions used. That was someone with access to the record had used that access to change it. The language was careful and procedural and entirely accurate. And underneath it was the much simpler fact that Gerald Prudhomme had removed a formal warning from Preston Parsmarlow's personnel file without going through the review committee, which was not a paperwork error. It was the deliberate protection of a man whose conduct he had known about and had chosen to cover. How long has it been going on? Nora asked. Loretta told the state board investigator that Prudhomme and Marlowe have known each other since medical school, Farron said. 23 years. 23 years, not institutional convenience. Personal loyalty, of the kind that makes people do things they know, are wrong because the alternative is watching someone they've protected for decades face consequences they've spent years helping him avoid. It was not an unfamiliar dynamic. It was, in Nora's experience, one of the most durable and destructive forces in any organization, the specific corruption of people who are not themselves cruel, but who enable cruelty, because the alternative requires a cost, decided not to pay. What happens to him? She asked. The state board has jurisdiction over Marlowe's license, Farron said. The records integrity review has jurisdiction over Prudhomme's administrative conduct. Solis flew in from Great Falls this morning. She didn't come for a board meeting. Came because someone I suspect Darrow told her last night that this was bigger than a departmental conduct issue, and she needed to be here in person. Nora looked out the corridor window at the dark valley below. Darrow knew, she said. Not a question. I think Darrow suspected. Farron said carefully, and spent 11 years not looking hard enough at what she suspected, and has spent the past 48 hours deciding that not looking was no longer a position she could hold. A pause. That's different from knowing. It doesn't make her blameless. It makes her human. She sat with that. It was accurate and it was complicated. And the complication was the part that mattered, because the easy version of this story had Darrow as a villain, and the real version had her as something harder to categorize, a person who had looked away and then looked and then made calls at 9:30 at night that cost her something she'd been protecting for a long time. People were not clean, even when they finally did the right thing. Especially then. Go home, Voss, Farron said. The rest of this runs on its own now. You don't need to be in the building for it. She went home. She slept 6 hours, which was more than the night before. And when she woke up, the particular weight that had been sitting in her chest since the first day she walked in to Kettner Valley Medical Center was still there, but had changed its character, not lighter exactly, but different. The way weight feels different when you're carrying it somewhere rather than just carrying it. The next 10 days moved with the specific momentum of institutional processes that have been set in motion by facts that are too well documented to slow down. The state board investigator arrived on Wednesday morning and spent 2 days reviewing records, taking statements, and meeting with Loretta Vane, whose documentation turned out to be more substantial than she had indicated on the phone. She had kept scanned copies of the original complaint, the warning that had been issued, and the removal paperwork with Prudhomme's signature on it, stored on a personal drive she had maintained since before she resigned, against the possibility that she would someday need them. The possibility had become a necessity, and the documents she had preserved with quiet, unglamorous foresight were now the foundation of a state board inquiry that had moved from preliminary to formal within 72 hours of her call. Prudhomme resigned his administrative position on Thursday. The resignation was described in the internal memo as voluntary and effective immediately. Was the language institutions used when the alternative to voluntary resignation was a formal removal process that would take longer and produce a public record that was more damaging than a clean departure. Issued no statement. His office was cleared by Friday. Marlowe did not resign. Nora had not expected him to, because Marlowe was not the kind of man who resigned. He was the kind of man who held his position until the position was taken from him, because holding it was the only response he knew how to make to a challenge, and letting go of it voluntarily would require acknowledging that the challenge was legitimate, was a concession his entire professional identity had been constructed to prevent. He retained a medical attorney on Wednesday. He submitted a formal objection to the state board inquiry on Thursday. He continued to show up at Kettner Valley, to his office and to his clinical cases, because his surgical privileges had not been suspended, and he was using that fact as the only remaining ground he had to stand on. She crossed paths with him once. During those 10 days, in the corridor outside radiology, on a Tuesday afternoon when she was returning a portable monitor, and he was coming from an imaging review. They were the only two people in that section of corridor for approximately 8 seconds, and in those 8 seconds, every accumulated weight of the past 3 weeks was present in the space between them: the administrative leave, the termination notice, the boardroom, the surgery, the state board inquiry, the 14 complaints, and the 3 nurses who had left, and the exit interview, and Prudhomme's signature on a piece of paperwork that held the whole structure together for years. He stopped. She stopped. He looked at her with an expression she had not seen on his face before, not anger, which she had seen, and not the controlled authority of someone managing a situation. Something older and less manageable than either of those things. The expression of a man who has spent 9 years being certain about something and is no longer certain, and who is aware that the uncertainty is permanent. You didn't have to go to the state board, he said. I didn't go to the state board, she said. Loretta Vane did. 14 nurses went to the internal panel. 3 former employees gave statements. Those are people you worked with for years, Dr. Marlowe. He said nothing. I just did my job, she said. That's all I ever did. She picked up the monitor and kept walking, and she did not look back because there was nothing behind her in that corridor worth turning around for. State Board issued its preliminary findings 6 weeks after the inquiry opened, which was fast by the standards of institutional processes, fast enough that it was clear the evidentiary record they were working from was unusually solid. The findings cited a documented pattern of retaliatory conduct toward nursing staff who raised clinical concerns, the unauthorized removal of a formal disciplinary record, and 2 specific incidents, the Pruett trauma bay case and the Steele misdiagnosis, as examples of how that pattern had produced direct patient safety risk. Preliminary findings did not yet constitute a final determination on Marlowe's license. That process would take additional months, with hearings and responses and the full procedural weight of a formal licensing action. But the preliminary findings were public record, which meant they were in the Montana medical community's awareness within 48 hours of release, and the specific language they used: retaliatory conduct, patient safety risk. Documented pattern was not language that could be walked back or reframed by a medical attorney with a press statement. Marlowe's surgical caseload at Kettner Valley dropped by 60% in the 3 weeks following the preliminary findings. Referring physicians made different choices. It was not dramatic. It was not announced. It simply happened the way reputations actually collapse not in a single moment, but in the accumulation of small decisions by individual people who have read something and updated their assessment accordingly. Nora was not present for any of it in any official capacity. She was on the floor, managing her patients, doing the work she had been doing since the first Tuesday in October, when she walked in with a duffel bag and a transfer file and a past she had been trying to keep quiet. The past stopped being quiet in the second week of November, when Duro called her into the fourth-floor office. Duro sat across the desk from her with the expression of someone who has done a significant amount of thinking and has arrived somewhere she didn't expect to arrive. There were no other people in the room, no administrators, no military liaison, just the two of them and the gray November light coming through the window and the sound of the hospital running at its normal frequency 4 floors below. The review panel has completed its assessment of your conduct file, Duro said. All findings have been reversed. Your record at this institution shows no disciplinary actions of any kind. Thank you, Nora said. I'm also here to offer you something, Duro said, and I want to be direct about why I'm offering it, because I think you deserve directness more than you deserve a polished presentation. She folded her hands on the desk. The nursing department at Kettner Valley has operated for 9 years in an environment where clinical concerns from nursing staff were systematically suppressed. That environment produced outcomes that cost patients, cost nurses, and cost this institution. We are rebuilding the structure of how nursing concerns are escalated, documented, and acted upon. I want to offer you the position of Director of Nursing Practice, a new role, not a renamed existing one, with genuine authority over clinical protocols and nursing advocacy. Nora looked at her. Why me? Because you demonstrated, in 11 days, exactly what this department has been missing. For 9 years, Duro said, and because I owe you an honest accounting of the fact that this institution failed you before it recognized you. And the offer of this role is not separate from that accounting. Part of it. Nora was quiet for a moment. She looked at the window and the gray November sky beyond it, and thought about the room on Kettner Valley Road, and thought about the room on Kettner Valley she had acted, with the intention of staying small and quiet and unnoticed, and how that intention had lasted exactly 11 days, before it ran into a tension pneumothorax and a man in a bed being treated for the wrong condition. She thought about Loretta Vane sitting in Idaho with a folder of scanned documents she had kept for 14 months on the chance that they would someday be needed. She thought about Russell's and his single nod. She thought about Diane Fuchs walking away down the corridor with a folder of notes she had written in private and locked away, and finally, at whatever cost, decided to use. She thought about 3 nurses who had left this hospital and gone somewhere else and built different lives, and about how one of them had told Russell she didn't think it was ever going to change. I need a week to think about it, Nora said. Duro nodded. Take what you need. Nora took 4 days. She spent them working her shifts, talking to Soledad on a Tuesday night over coffee in the break room, and sitting at the kitchen table in the room on Kettner Valley Road long enough to be honest with herself about what she actually wanted versus what she had trained herself to want, which were 2 different things that had been occupying the same space for long enough that separating them required more effort than she'd expected. What she had trained herself to want was invisibility. Quiet competence in a small space, doing good work that nobody looked at too closely, protected from the cost of being seen by the simple expedient of not being seen. She had built that preference out of genuine pain, out of the experience of being visible in environments where visibility had a price she had paid more than once. It was a rational adaptation to a real experience. It was also, she admitted to herself on the third night, a way of making to herself on the third night, a way of making herself smaller than she was, for the benefit of people who had never deserved that accommodation. She had never been small. She had only ever acted small, and the acting had gotten harder every year. And at Kettner Valley Medical Center, It had lasted exactly 11 days before her actual size became impossible to conceal. Called Duro on the fourth day and said yes. The formal announcement went to staff on a Monday morning, 2 weeks before Thanksgiving. Director of Nursing Practice, a new position, Nora Voss appointed effective the 1st of December. The announcement was 3 paragraphs. It described the role's responsibilities, clinical protocol oversight, nursing advocacy, formal escalation pathways for clinical concerns, without describing the circumstances that had made the role necessary, because the staff already knew those circumstances and didn't need them recited. The response in the building was not uniform. Some staff were openly glad. Some were reserved, waiting to see what the role actually looked like in practice before deciding what to make of it. A few of the physicians who had been comfortable in the previous structure were visibly unhappy, not dramatically, but in the specific way that people are unhappy when an equilibrium they've benefited from is disrupted. She noted all of it and treated none of it as either a victory or a problem, because it was simply the accurate picture of a place in the middle of changing, which meant it was messy and unresolved and real. General Steele was discharged from Kettner Valley on a Thursday 22 days after his surgery. His neurological function had returned to baseline. The post-operative imaging showed complete hematoma clearance, and Dr. Sungs had signed off on the discharge with the specific satisfaction of a physician watching a case resolve the way it was supposed to. Farron and Reeves were there for the discharge. Calloway had returned to her posting 2 weeks earlier. Nora was on shift when Steele came through the second-floor corridor on his way to the exit, moving with a cane he didn't entirely need, and at a pace that was slower than his natural one, but would not stay that way. He stopped at the nursing station when he saw her. "Voss," he said. "General," she said. He looked at her for a moment with the directness she had first seen on the morning she walked into his room and asked him to give her honest answers. "I heard about the director position. Word travels fast," she said. "In small hospitals it does." He shifted his weight on the cane. "For what it's worth, and I know you didn't do any of this, for what it's worth from someone like me, you did something here that most people wouldn't have done. Not because of the surgery, because of every day before it." She looked at him. "You did something too," she said. "You told the board what you saw. You didn't have to do that." "Yes, I did," he said simply. And she understood that he meant it the way she meant it when she said she was just doing her job, not as a deflection, but as an accurate statement of what it felt like from the inside when the thing you did was simply the only thing you were able to do, given who you were. He shook her hand and walked toward the elevator, and Farron, who had been standing slightly behind him, gave her a look on his way past that carried the same information as Russell's nod, the compressed acknowledgement of someone who observes carefully and speaks economically and says everything they need to say without using many words to say it. She watched them go, then turned back to her station. State Board issued its final determination 4 months later. Preston Marlowe's license was not revoked. It was restricted. He could practice medicine, but not in a supervisory or departmental leadership capacity, and his practice was subject to a 2-year monitoring period with quarterly reporting requirements. It was not the most severe outcome possible. It was not a clean exoneration of what he had done, either. It was the outcome that the evidence supported and the process produced, which was what outcomes were. And she had learned a long time ago that demanding that justice look exactly like what you'd imagined it looking like was how you missed the actual thing when it arrived. He resigned from Kettner Valley the week after the final determination. No statement. His office was cleaned out on a Friday, and by Monday the trauma department was operating under interim leadership, while a national search was conducted for a permanent and the 14 complaint files that had been closed without action were formally reviewed and entered into the department's corrective record, which meant they existed now in a way they hadn't existed before, not as buried things, but as part of the documented history of how the department had functioned and what it was going to stop functioning like. Diane Fuchs did not leave. She stayed on as charge nurse, which surprised some people and didn't surprise Nora at all. Diane had stayed through 9 years of doing things she didn't agree with because the cost of not staying had seemed higher than the cost of complying. And the moment the cost structure changed, she had picked up a folder of private notes and walked it to the review panel. That was not the action of a person who didn't care. It was the action of a person who had been waiting for the conditions to change and had used the time while she waited to keep a record. People were more complicated than the worst things they'd done under pressure, and Diane Fuchs was a better nurse than what 9 years under Marlowe had required her to be, and Nora minced no interest in pretending otherwise. On her first official day as director of nursing practice, Nora stood in the second-floor conference room with 23 nurses from across the hospital's departments and said what she had decided to say, which was not a speech and was not a vision statement and was not the kind of thing that looks good on a plaque. Most of you have had the experience, she said, of knowing something was wrong with a patient and not saying it, or saying it and being told you were wrong, or saying it and watching nothing happen. That experience costs something. It costs the patient, and it costs you, and it costs this building its ability to do what it's supposed to do. She looked around the room. That's what this role exists to change, not by making speeches, by building a system where what you know has a way to become what happens. That's it. Nobody applauded. A few people nodded. One of the nurses in the back, a younger woman, Nora, didn't know well, yet was writing something in a notebooks with the specific focus of someone who has heard something they want to keep. That was enough. The work that followed was not cinematic. It was documentation reviews and protocol rewrites and difficult conversations with physicians who were accustomed to a particular balance of power and were being asked to accept a different one. It was a formal escalation pathway that took 3 drafts to get right and still needed revision 6 weeks after implementation. It was Soledad coming to her office at 7 in the morning with a clinical concern about a patient handover process and Nora sitting with it for 40 minutes until they had an approach that was actually workable rather than just procedurally correct. It was the work. Unglamorous, specific, slow-moving, and exactly what the place needed. Nora did not think of herself as a person who had won something. She thought of herself as a person who had stopped pretending to be smaller than she was and was now living with the full consequence of that, the cost of visibility, which was real and ongoing, and the thing that came with it, which was harder to name, but felt like having both feet on the ground for the first in a long time. She had built her entire Harlow Creek life on the premise that staying quiet was the staying safe. 11 days had shown her that the premise was wrong. Smatchen's more. Staying quiet had never been safety. It had been the specific vulnerability of someone whose skills are known only to herself, who has no allies, because she's never let anyone close enough to become one, who can be dismissed with a conduct file, because there's no record of what she actually is and what she's actually done. She had been trying to protect herself by making herself easy to ignore, and what she had protected was not herself but the system that needed her to be ignorable. That was the thing she carried forward. Not as a wound and not as a lesson she'd learned cleanly, because she had made real choices based on a real fear, and the fear had been real, and the choices had made sense at the time, and she was not interested in pretending otherwise. She had done what she had done for reasons she understood, and those reasons had produced a decade of half-living, and now she was not doing that anymore, and the adjustment was ongoing and imperfect and hers. Loretta Vane called her in January. She was still in Idaho, still nursing, and she had been contacted by the state board to provide testimony in the final licensing determination. They talked 40 minutes, which was longer than either of them had expected. And at the end of it, Loretta said something that stayed with Nora in the specific way that simple, true things stay. I filed that exit interview because I thought maybe someday someone would read it, she said. I didn't think I'd ever know whether anyone did. Someone did, Nora said. Yeah, Loretta said. 14 months later. She was quiet for a moment. I used to think that was too late. Now I'm not sure there's such a thing. Nora thought about that for a while. All ended. She thought about all the documentation that existed, Loretta's folder, Diane's private notes, Russell's internal record of everything he had observed and categorized and filed away in the accurate ledger he kept behind his eyes, and how none of it had been nothing, even when it had seemed like nothing. It had been accumulation, the slow, unglamorous, deeply human process of people keeping track of what they knew was wrong and holding on to it against the possibility that someday the conditions would change. The conditions had changed, not because of a single heroic act, because enough people had kept enough records for long enough, and one person had stopped acting small long enough for the records to find daylight. She sat at the director of nursing practice desk in her small office on the 4th Kettner Valley Medical Center on a January morning with snow coming down outside and a stack of protocol revisions. She was 3 hours from finishing. And she thought about the person she had been when she arrived in October with a duffel bag and a deliberate gap in her file, and the person she was now, and the distance between them, which was not as far as it seemed but had cost more to cross than she'd expected. Picked up her pen. She finished the revisions. She had learned, in the end, that silence is not protection. That competence hidden is competence wasted, that the people who needed her to be small were exactly the people who could not afford her to be anything else, and that the most dangerous thing a person with her particular skill set could do was exactly what she had spent years doing, standing at the edge of every room she entered, waiting for permission that was never going to come from the people who needed her to keep waiting. She had stopped waiting. It had cost her something. It had given her back more. Some things only move when someone decides to stop accommodating the conditions that keep them still. Some rooms only change when someone walks through the door and refuses to stand at the edge of them. Some silences have to be broken, not because it is easy or safe or welcomed, but because the alternative is allowing the wrong things to keep happening to people who deserve better. That was what Nora Voss knew. Now, with both feet on the ground, in a hospital that was becoming slowly and imperfectly, and without any guarantee of permanence, a place where the people who saved lives were allowed to do it without first proving they were willing to disappear. It was not a perfect ending. It was a real one, and she had stopped needing those two things to be the same.